ஸ்டார்டிங் அவனை போக திருப்பி இது ஒன்றும் இல்லை. அவர் அந்த கடை அது இங்கிட்ட இல்லை சார். அங்கிட்ட வந்து அங்கிட்ட இறைச்சி கிற மாதிரி தான் ஒன்று இருக்கு. பார்த்தேன் இங்கிட்ட தான் ஏதோ இருக்கு. அது இப்போ இருக்கிறது தெரியாது சார். நம்ம அர்ஜென்ட் தான் சரி சார். இருக்குல்ல இதுல இப்போ இதுல போகிறோம். ஹோட்டல் நான் பண்ணோடனே அவ்வளோதான். ஸ்ட்ரைட்டாக போயிட்டே இருந்தோம்னா அதுதான் எங்களோட அங்கதான் போதா ஸ்ட்ரைட்டா அந்த ஒரு ஆமா நம்ம அப்ப நீங்க கரெக்டா தான் வந்தீங்கன்னா ஆமா ஆமா அன்னைக்கு வந்து
Good afternoon, Senthil. Senthil, am I audible?
Yes, sir. Audible, sir.
Jailal sir, நம்ம ஸ்டார்ட் பண்ணலாம். ஆல்மோஸ்ட் நந்தகோபன் சார், ஆனந்த் சார், விஜயகிருஷ்ணன் சார் இருக்கும். தன்சேகர் சார் வந்துருவாருன்னு நினைக்கிறேன். ஹோப்ஃபுல்லி.
Okay, sir.
ஜெயலலிதா சார் மட்டும் வந்தோன்னா we can start. ஒன்றும் விசேஷம் இருக்காது.
We'll start, sir. Yes, sir.
என்ன சொல்லுங்க?
IMA prayer நீங்க வச்சிருக்கீங்க இல்லைங்க சார்? Yes. Prayer, IMA prayer, sir.
இப்போ நான் பண்ணிடுறேன், நான் வச்சிருக்கேன்.
Okay.
ஓகே.
வரலையா?
ஆனந்த்
Sir, sir. Sir, good evening, sir. Yes.
ஜெயலலிதா சார் ஜாயின் பண்ணுறீங்களா செந்தில்?
Yes, sir. Join பண்ணிட்டாரு.
சார் வெல்கம் ஜெயலலிதா சார். குட் ஈவினிங் சார். டாக்டர் ஆனந்த் சொக்கலிங்கம் சார். செந்தில் சார் ஆடிபிளா இருக்காரா?
Yes. Sir, Gerald sir, good evening, sir.
சார் அன்மியூட் பண்ணணும்.
இல்ல அவர் அன்மியூட்ல தான் இருக்கு.
Yes.
செந்தில் சார் டிராவல்ல இருக்க வார்த்தை பேசிடுங்க. பேசி சொல்லிட்டு நம்ம ஸ்டார்ட் பண்ணிடலாம்.
கேக்குதா? சார் பேசுறது கேக்குதா?
ஆனந்த் அன்மியூட் பண்றதானே? வெளியே தெரியுறீங்க. நான் பாத்துட்டேன் உங்களை போன் பேசுறது. ஆமா
இல்ல ஏன் அது கேட்க மாட்டேங்குது? சார்
சார் ஸ்டார்ட் பண்ணுங்க. சார் குட் ஈவினிங் ஜெயலலிதா சார். சார்
Yes. Yes. Yes.
good evening, sir. Yes, sir. Audible, sir. Yes, sir. Shall we
Okay,
start,
okay.
sir?
Yeah, go
Yes.
ahead. Go ahead.
Yes, sir. A very good afternoon to all the participants of today's webinar. A very warm welcome on behalf of the CGP wing. I welcome you all for the third day of our state CGP conference. And today's topic is going to be an interesting topic, which is I usually spoken of well about in ENT forums and respiratory medicine forums. But we thought, why don't we bring it to first line of contact with the general practitioners? So we have got a stalwarts in each field, 2 from respiratory and 2 from ENT, who practice field medicine day to day. So I think it will be useful for you. First, I will start initially with the IMA prayer and precision prayer. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody free from sorrow. May we be the healing cure beyond every greed and lure. Physician's prayer. Dear Lord, thou the great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray give skill to my hands, clear vision to my mind, kindness and sympathy to my heart, singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of rare privilege that is mine. Take from my heart all guile and wildness, that with the simple faith of a child I rely on thee. Thank you. Now I request our Director of Studies, Dr. Sandil Kumar, to give the welcome address. Dr. Sandil.
Thank you, sir. So I welcome our chief guest for the day, Dr. Jailal sir, President, Commonwealth Medical Association. I welcome the speakers and moderators for the day, Dr. Nandagopal sir, Dr. Dhanashekhar sir, Dr. R. Anand sir, Dr. P. Vijay Krishnan sir, and of course our moderator, Dr. Ananda Chukkalingam sir. And I welcome all our delegates who are online now and about to join. And I would like to share the news that we are running with the registrations of 2,800 plus, and it's a big achievement. With all your support, we have done this. Hope it will be useful for all of you. And I request all the members to make the session useful and informative for your day-to-day practice. Thank you, sir.
Thank you, Dr. Sandhu. Now I request our chief guest of the day, Professor Jayaram sir, the President of Commonwealth Association of Commonwealth Medical Association, to give his words of felicitation in the presidential address. Jayaram sir. Jayaram sir.
Yes.
Sir.
Yes, sir. Audible,
Thank you,
sir. Yes.
Sendil and Anand Chokalinga. I think I'm sorry because I'm traveling. I'm not really sure of the net connectivity, but indeed it is a great privilege.
So your voice is breaking up, sir.
Yes, sir. I think it will resume. Yes, sir. Yes, sir. Audible, sir.
IMA College is the tool or the process through which that it has been implemented. I'm extremely happy about the IMA-CGP of the Tamil Nadu state, especially both Dr. Sendil and the team and all that doing a fabulous job. It is heartening to know that 2,800 people are registered for the CME program, which is spanning across a week. This is a very innovative thing. I think for today, the topic is also very interesting topic of sleep apnea and the sleep related issues. So this is one of the growing problem among our population as the obesity is increasing. This is becoming also a big challenge, and also a lot of external stimulus are increasing with audio visual, Facebook and the Twitter, the social media. That is playing a major role in psychologically disturbing the sleep. Also, there is a lot of anatomical reasons which are there, and the sleep has gone to beyond the level of comprehension even. Then there are newer techniques are coming even for a surgery for sleep apnea, robotic surgeries for sleep apnea, and a lot of meditations, yoga, and the methods of focusing issues at which we definitely believe the sleep and intelligence and the health are interconnected with that. And those who have a good sleep and definitely will have a good peace of mind and will be able to do a lot of good output in their life. So in that way, I think it is very good that IMS-CGP has identified that issue and today going to disseminate the latest informations which are available with the sleep and how to tackle it and how to overcome that. And we have a very expert speakers, including Anand Chokalingam, and we are eagerly awaiting to hear from them. I'm sure as we are going to listen from the sleep apnea, nobody will sleep, and but at least after this class, they will have an opportunity to have a good sleep because you are going to tell us a lot of tricks and traits of that good sleep. So it is as an health advocacy, Indian Medical Association always stand for on two counts. One is physical health of our own doctors, but as we firmly believe only when the doctors are healthy, they will be able to give the health tip to their the patients. So we are. It is not an objective of reaching out to the patients, but more so with our own doctors that we should have an opportunity to have a good sleep in their life, and so that they will be able to have that confidentially they can face the public and do the necessary things. So once again, I take this opportunity to congratulate the organizers, especially our IMA College of GP, for your yeoman service for the last, for this starting from the 4th and Monday. You are going to have a 1 week program and it is going to be culminate on Sunday. I wish all the best, and I wish all the delegates to utilize this opportunity, get to know about the latest and utilize in your life, have a good sleep so that the mental strength will be strengthened, that you will be a great ambassadors of peace and health to the society. So thank you, Sendil, and thank you, Anand Chokalingam, for your excellent activities.
Thank you so much, sir.
Thank you so much, sir. Thank you for a very kind words of felicitation, sir. We would like to live up to the expectations as you told, sir. Thank you very much, sir.
Thank you.
Now, before going into the per se going into the our topic for the day, I would like to, as a moderator, I would like to introduce the speaker one by one. So, as you saw, the today's session is called "Breaking the Sound." The sound is within apostrophes, and sleep and ENT in pulmonary perspective. See, what do we mean? In the olden days, when we thought that when a person is snoring and sleeping, the elders, when we were children, the elders used to say, don't disturb your father, he's very tired, so he's having a very good sleep. So it was the case then, but that snoring or the sound of sleep, which was considered healthy long back, 30, 40 years back, now that's become a menace. So not only menace, it has led to many lifestyle problems, many divorces are happening because of this snoring, and many things are going on. So now the sleep medicine, or we call it as sleep disorder breathing, has evolved into a specialty by itself, where a dentist can treat, where a neurologist can treat, where a pulmonologist can treat, where an ENT surgeon can treat. So ultimately, it becomes a confusion for the end patient. Who he develops the story, he will have confusion like whom to go and what to say. So, as the prime motto of our College of General Practitioners is to equip the general practitioners in each and every specialty, so that when when they come across or when they confront the patient with similar complaints, so they can at least treat it primarily or at least give a reference to which specialist they should go. So we thought we will combine two common doctors where a patient with snoring goes now. One is an ENT surgeon and one is a respiratory medicine. So it's a paradox where both medical and surgical management, like management of allergic rhinitis, is combined together. So that this will be, I think, this webinar today with all star speakers. The two from pulmonology, namely Dr. Naval sir and Dr. Research Foundation, Chennai. So those two are ENT surgeons. I will start CV before we start their presentations. Now, first, the first topic for the day will be by Dr. Sir, the consequences and complications of sleep apnea. So many of you might be knowing he is the coordinator for the fellowship in respiratory diseases, which we conduct on behalf of ILA CGP. Sir is the coordinator. He is a consultant pulmonologist at Hindustan Hospitals, and he is obviously consulted in many of the centers in Coimbatore. And he's very much interested in the subject, and he also practices sleep medicine to a lot of extent. First I call upon sir to give his topic for the day: consequences and complications of sleep apnea. Welcome, sir.
Good evening. Good evening. Can you hear me now?
Yes, sir. We are hearing, sir. A little bit.
Yeah.
Yes, sir.
Yeah. I will just start sharing the.
We are able to see you, sir. You can share your slides.
Yeah. Now we can see this. Yeah. Can you see my slides, sir?
Yes, sir. Yes, sir. You are visible, sir.
Yes.
It's visible, sir.
Yeah. Yeah. Thank you. Thank you. First of all, let me bring my wishes and greetings from the Institute of Lung Care Group to the organizers of this magnificent program, which has brought in more than almost close to 3,000 registrations, which is phenomenal number. I think Dr. Anand Chakulingam sir and Dr. Senthil Kumar deserve a big applause for bringing such a diverse specialties into one single forum and making sure that it reaches all the general practitioners. And I should also thank the IMA state leaders and Jailal sir for expanding the horizon. So without taking much time, let me just go into the topic, which is sleep apnea, consequences and complications. I will limit myself to adults, in which I have more of an experience. Like a lot of people think sleep apnea as a problem of the sleep. So let me just give you a brief overview. My next 30 to 40 minutes is going to be, this is the agenda. I'm going to just introduce with an overview of sleep apnea, pathophysiology, epidemiology, and diagnosis. I'll just go into the respiratory complications before going into the cardiovascular, metabolic, neurologic, and quality of life effects. This is a brief overview. And the next part of the agenda will be covered by the prominent speakers, eminent speakers, next three of them, who are specialists in their own way in like Dr. ENT surgeons. Both the ENT surgeons are there. Dr. Anand is going to talk about a comprehensive evaluation of a sleep apneic patient from medical and surgical perspective. Dr. Vijay is going to talk about surgical management, and Dr. Dhanashekhar is going to talk about the medical management of sleep apnea. So I'm going to just touch upon these 4 points. I'm not going to talk much on this. So what is sleep apnea? Sleep apnea is I have on one note I'll give you. I have made it very, very simple. I'll give a disclaimer. I'm not going to quote any studies. I'm not going to put any big statistics to argue, but it's starting with statistics, I know, but it's not going to have any of the big studies or the data or the structures to confuse you. I made it as simple as possible. Sleep apnea is a serious sleep disorder. It is characterized by repeated interruptions in breathing. These usually occur in the obstruction in the upper airway. These breathing pauses, otherwise known as apneas, typically last 10 to 30 seconds, and potentially they can occur hundreds of times per night, leading to a fragmented sleep. What do you mean by fragmented sleep? In a 6-hour sleep, it's supposed to follow a certain pattern from stage 1 to stage 2, and the stage 3 and 4 of the previous classification now put us together as stage 3, which is a deep sleep, and then go on to REM sleep. Then from that the cycle has to repeat itself. But this proper cycling of sleep does not happen in sleep apnea because of the reasons you will see, and this is going to cause a lot of trouble. What else it's going to cause is, because of the breathing pauses or the apneas, it can also cause decreased oxygen levels, which again is going to play havoc in our body. So there are a couple of major types of sleep apnea, and third is a mixed. The obstructive sleep apnea is the most common form. It is caused by basically a physical blockage of the upper airway. Central sleep apnea is much less common. It caused by the failure of the brain to signal breathing muscles. Here we are going to talk more on obstructive sleep apnea. And the mixed or complex sleep apneas is combination of both obstructive and central features. The diagnostic criteria, we have to do a study called polysomnogram, which we'll talk about in detail later. This polysomnogram will give you one index, which is called apnea hypopnea index. Basically, what do you mean by apnea? Is complete breathing pause. Hypopnea is a reduction more than 50%. This both put together as an index over an hour. If this is 5 to 15 events per hour, it is mild OSA. Less than 5 is normal. Moderate is 15 to 30, and severe is more than 30 events in an hour. So how often it affects people? Much more than what we think. The prevalent statistics are shown here. 24 to 26%, that is 1 in every 4 middle-aged adult can get affected. Much less in women. 9 to 12% of middle-aged adult. Globally, it is affected almost 936 million. Worldwide, it has mild to severe. And the most important part is more than 80% or up to 80% of the cases remain undiagnosed. So how do they get diagnosed? We will see. So what is the pathophysiology of sleep apnea? What basically happens in obstructive sleep apnea is a upper airway collapse, upper airway constriction or an obstruction. relaxation of pharyngeal muscles during sleep, which may be caused by both anatomical factors or neuromuscular factors. Anatomical factors are narrow airway, enlarged tonsils, much more seen in children, excess soft tissue, which can be because of the fat deposition. And neuromuscular factors, basically decreased muscle tone in pharynx. Whereas this is the cause for obstructive sleep apnea. In central sleep apnea, there is a control center dysfunction. Brain fails to transmit signals to the breathing muscles to breathe. So that causes a apneic. We all would have read in our physiology days about the Ondine's curse. Basically, central sleep apnea, as the brain is failing to transmit the signal to the respiratory apparatus to breathe. So Cheyne-Stokes respiration is a type of central sleep apnea. We can call it crescendo-decrescendo breathing pattern, which we see in certain serious illnesses. And the contributing factors for central sleep apnea are heart failure, stroke, and high altitude exposure. Complex sleep apnea exhibits both obstructive and central features. Basically, it looks like an obstructive sleep apnea. When we diagnose it erroneously as obstructive sleep apnea and start on CPAP treatment, it appears. Then we know it's a complex sleep apnea. So how does it affect? What are the basic physiological consequences for the sleep apnea? So the consequences are basically 2 or 3 in nature. One is reduced oxygen. So hypoxemia, the reduced blood oxygen levels during apneas, it causes certain consequences and complications, which we will see in the coming slides. The sympathetic activation, what happens is because of this reduced oxygen levels and also reduced breathing, there is a imbalance between the sympathetic and parasympathetic levels. So suddenly there will be a sympathetic activation because there is a pause of breathing. So there is a surge in stress hormones, which causes increased heart rate. So from a basal vagal tone, where there is a reduced heart rate, there is a sudden surge causing increased heart rate. Third aspect is the arousal response or the sleep arousal from the sleep. It's not a proper awakening, but it's an arousal from the person who's suffering from sleep apnea starts from the level of a deep sleep, but because of apnea, he goes into the light sleep or even into an arousal stage, but he doesn't get awakened completely. So this causes that fragmentation. They need to have a one long like we can have multiple small and 1 or 2 long spells of deep sleep. So this long deep sleep faction does not happen in sleep apneics. So there is a sleep fragmentation. What does it all do? Finally, there is an oxidative stress because of the increased heart rate, sympathetic activation, hypoxemia, and the sleep fragmentation. There is a huge burden of oxidative stress on causing increased inflammation and increased free radical production. So the epidemiology, coming back to that, more than 936 million adults worldwide have mild to severe, and almost half of them out of this have a moderate to severe OSA. This is not mild. So prevalence is varying by region, 27% in Americans and 40% in Western Pacific. The Indian data, of course, we don't know it properly. All we know is there are certain primary risk factors like modifiable, and we can divide them into modifiable and non-modifiable. The modifiable risk factors are BMI more than 30, smoking, alcohol consumption, and nasal congestion. Sorry about the slides. There is a little formatting error. So the non-modifiable risk factors, male gender, men are having 2 to 3 times higher prevalence than women. Advanced age, there is a genetic predisposition, and there are certain craniofacial abnormalities which could not be said as non-modifiable because there are surgical modifications which are possible, but there are certain abnormalities which can be corrected en masse. So there is a population which is around 50% is having a mild OSA, but almost an equal amount have both moderate and severe OSA. So what happens is there is a huge impact on the weight on OSA. So if there is a 10% weight gain, there is a 32% increase in the apnea-hypopnea index. So the best treatment for OSA is going to be loss of weight, because 10% weight loss is going to result in 26% decrease in apnea-hypopnea index. So age, again, the prevalence increases with the age, peaking around 6th and 7th decades. 50 to 70-year-old people do have the maximum number of sleep apnea prevalence. And clinical impact is, again, even in case of moderate to severe OSA, almost 80% remain undiagnosed. So this leads to a lot of complications. So if we can diagnose sleep apnea early, whatever I'm going to speak from here onwards can be prevented. So how does it come? How does it show? Symptoms of sleep apnea are, we can divide them into nighttime symptoms and daytime symptoms and associated symptoms. What are the nighttime symptoms? Loud, chronic snoring. So loud. How loud? Often loud enough to be heard from another room. So witnessed breathing pauses, that is a partner, what we call it as an elbow test. So the partner will be observing episodes where breathing completely stops. Initially, they will get panicky. So what happens is, this partner, who's a bed partner, who's either a husband or the wife, who was along with the patient, they will be initially disturbed because of the snoring. The snoring will keep increasing in turn. Suddenly it stops. So this person initially panic. Though panic and see whether the patient is really breathing or they've stopped breathing. Because what they would have again witnessed is some gasping or choking during sleep also. They would have witnessed earlier. So this gasping or choking episodes combined with sudden breathing pauses, it will make them panic. So they will really think, is my partner okay? Is he alive or is he dead? Something like that. So then they will shake up only to see that the patient does not even get up from the sleep. They will continue to breathe and they'll again start snoring. After a certain 1 or 2, probably 3 or 4 or 5 or 6 episodes, the partner get used to this. So then every time the breathing stops, they just elbow the person next to them so that the breathing again starts. So this is called the, we ask the bed partner, have you ever elbowed your partner to make sure that he's breathing? So this is witness breathing pauses. Night sweats, excessive perspiration during sleep is again one of the nighttime symptoms. What are the daytime symptoms? Because of the problems which are happening at the night, daytime when the patient gets up, there is a dull headache which they can't decipher exactly upon awakening from the sleep. Excessive daytime sleepiness, feeling tired despite seemingly adequate sleep time. Particularly, this will become more pronounced. What will happen is, the person will go and tell his wife that, okay, I'm really feeling sleepy now. I'm not feeling going to work. The wife will be looking at him, you are slept and you are snored so much that I couldn't sleep for the whole night. Now you are getting up and telling that you can't sleep. You wanting more sleep. No, just go to work. Don't do it like this. So this is the usual thing. Excessive daytime sleepiness will be there. That is a feeling of tiredness despite adequate sleep time. So the third point is difficulty concentrating, the problems with attention, focus, and memory. These are all the direct symptoms. So what happens as an associated symptom is hypertension. Although I can't call it as a symptom, the resistant morning hypertension is a point to look for sleep apnea actively. If your patient is on a couple of antihypertensive or 3 antihypertensive medication, if the BP is not come down, don't look at anything else. First, look at sleep apnea as the possible reason. So that will, once the sleep apnea gets treated, the number of pills and the dose burden for hypertension medication will come down. So the mood changes, irritability, depression, anxiety, all that is going to caused because of sleep apnea. Reduced sexual interest and function, and nocturia is one of the most common symptoms. Frequent nighttime urination is one of the most common symptoms, and this is the first symptom to get corrected once the sleep apnea is corrected. So symptoms often they develop very, very gradually. They may go unnoticed by patients emphasizing the importance of screening at-risk individuals. So the diagnosis is going to be talked about in detail. So I'm not going to talk much, but you have to see that there is a 3 or 4 step process. It is by a detailed sleep history with certain questionnaires like Epworth Sleep Scale, stop band screening tool, and having a like other questionnaires like Berlin questionnaire, physical examination having an important towards neck circumference, BMI, and the airway assessment where the tonsils are enlarged and what is the Malambetti grading, like that. And the test, which is polysomnogram, which is a gold standard diagnostic test, which is conducted in the sleep laboratory. There are multiple levels of sleep test polysomnogram, which will be talked about later. So this has all the brain activity, eye movement, muscle activity, heart rhythm, everything put together along with the oxygen saturation and the heart rate and rhythm. So this gives us a lot of data from which the interpretation of sleep apnea, whether mild, moderate, severe, is done. So there are other tests which is for a non-lab based test. That's a home sleep apnea testing is for uncomplicated OSA cases. There is a limited channel recording. It is more convenient and cost effective, but the downside is it will miss the complex or subtle sleep disorders. So severity, yes, again, AHI less than 5 is normal, mild is 5 to 15, 15 to 30 is moderate, and more than 30 is severe. There are certain classifications which even say that 5 to 25 is moderate and more than 25 is severe. So the point which we have to note is 80% of moderate to severe OSA remains undiagnosed. Polysomnogram has a 97 to 100% sensitivity for an obstructive sleep apnea, and the sleep apnea testing at home has an excellent sensitivity between 85 to 95%. If somebody is you think that the patient is having a sleep apnea, your clinical index of suspicion is very high, but the home sleep apnea testing comes as negative, please subject them to a lab-based testing. So let's go into the systematic complications and why this should be detected early, why we are stressing so much on sleep apnea. So it is just a snoring, it's just a disturbance. So I will start, being a pulmonologist, I will start with the respiratory consequence of sleep apnea, which can be significant and can impact lung function, breathing, and overall health. So what we need to consider is, first is pulmonary hypertension. We have talked about hypoxia. So this can result in increased pulmonary artery pressure, and which can go into have a untreated pulmonary hypertension, can have a right heart failure. Any person who is having a COPD can have both together. This is called an overlap syndrome. OSA and COPD can coexist, leading to an overlap syndrome, which can worsen respiratory symptoms. Increased respiratory symptoms, basically the COPD person, if they have an comorbid OSA, they can increase or exacerbate the respiratory symptoms such as shortness of breath and wheezing. What happens in obese patients who are already having COPD and they also have sleep apneas? There is an increased risk of a respiratory failure, particularly with any chronic lung disease, more so in a COPD patient. And patients, when they have a small exacerbation, they can acutely decompensate. So they can lead to acute respiratory decompensation, requiring hospitalization. The other respiratory consequences could be the triggering of nocturnal asthma symptoms such as coughing and wheezing, the obesity, which can cause a hypoventilation, which is a sleep-related hypoventilation. In these patients, if they also have an obstructive airway disease, this can worsen respiratory acidosis, or it can bring about the respiratory acidosis in a much faster and much quicker way before we can realize. And because of the obesity and OSA may increase the risk of pneumonia, particularly in elderly people. So how does it come? Most of the systemic complications come because of couple of mechanisms, which is, one is intermittent hypoxia. What happens is, this patient, when they sleep, they get into a breathing pause, the oxygen level comes down, so this creates a trigger with chemoreceptors, so that triggers the brain, and the brain signals for the respiratory apparatus, and they start breathing again. So the oxygen level keeps fluctuating between normal to abnormal. So this repeated episodes of hypoxia can lead to a pulmonary vasoconstriction, which leads to pulmonary artery pressure. This intermittent hypoxia will be a cause for many, many reasons, which we'll see now. So inflammation, this can lead to inflammation in the lungs, which can contribute to respiratory dysfunction because of the increased respiratory load leading to respiratory and muscle fatigue, and the inflammatory cascade of events which can worsen which can add to the hypoxia induced inflammatory events, cause the worsening of pulmonary vasoconstriction and other cardiac complications, which we will see. So what is the importance of treatment in such patients? This treatment can improve the lung function, reduce the respiratory symptoms. It reduces the pulmonary hypertension. One of the easily reversible cause of pulmonary hypertension is obstructive sleep apnea. A prompt, proper treatment of OSA can reduce the pulmonary hypertension, then it can improve or almost near normalize the right heart function. It also improves the overall health. So coming from respiratory, let's go to the cardiovascular. See, respiratory is directly connected because there is an airway, there is an oxygen and other aspects. But we will see from now what are the other complications which will affect other systemic complications which can be because of sleep apnea. So from this slide, you can see there is a multitude of cardiac events which can be worsened because of sleep apnea. Again, the basic pathophysiological mechanism is same: intermittent hypoxia, sympathetic activation, systemic inflammation. கீரலோட இந்த ரெக்கார்ட்னு சொல்லுவாங்க. அந்த மாதிரி இந்த 3 வார்த்தையை நான் திருப்பி அடுத்த 10 நிமிஷத்துக்கு பேசிட்டே தான் இருக்க போறேன். இன்டர்மிட்டன்ட் ஹைபாக்சியா, சிம்பத்தட்டிக் ஆக்டிவேஷன் அண்ட் சிஸ்டமிக் இன்ஃப்ளமேஷன். ஸோ hypertension, the hypertension is present in 50 to 60% of patients with OSA. OSA is found in up to 80% of patients with resistant hypertension. Please remember, if your patient is on more than 2 antihypertensives and if the BP is not getting control, think sleep apnea and evaluate for sleep apnea. So the severity of OSA correlates with hypertension risk and the blood pressure levels. The pathophysiological mechanism, again the same: intermittent hypoxia causing sympathetic activation, causing oxidative stress and systemic inflammation. There is an endothelial dysfunction which affects the blood vessels, causing the also affects the renin-angiotensin aldosterone system and impaired baroreflex sensitivity also. So it contributes to a non-dipping blood pressure pattern. Usually, normally and nocturnally, the BP has to reduce, and early morning the BP should be low. But there is a non-dipper pattern. This is the OSA's effect. So how does the treatment compensate? There is a BP reduction, which is much better in resistant hypertension cases, correlating with the CPAP adherence. And the AC inhibitors and ARBs should be preferred, and the evening dose should be given in patients with OSA to counteract the non-dipping pattern. So any patient with a resistant or nocturnal hypertension, screen for OSA. That is a clinical recommendation. So again, sorry about the slide. The connection to sleep apnea with the ischemic heart disease is there. Multiple studies have been done. The OSA patient showing 2 to 3 times the higher risk of developing ischemic heart disease. Again, the problems are the same: intermittent hypoxia triggering oxidative stress, sympathetic activation causing the increased heart rate, blood pressure and myocardial oxygen demand. Not just it's a sympathetic activation, there is a constant fluctuation. So there is a basal tone which decreases the heart rate. The sympathetic activation will suddenly increase the heart rate. Similarly, the BP will come down to normal sleep levels, the low basal levels. Suddenly this will increase. So this keeps on happening throughout the night. That is going to cause more strain on the system as such. And it also causes endothelial dysfunction, promoting atherosclerosis and systemic inflammation. All this is going to not just result in increased hypertension, ischemic heart disease. You will see these are the resulting factors or the causative factors for other cardiac events as well. So OSA is associated with a 70% increased risk of coronary artery disease, higher prevalence in established coronary artery disease, and even treatment of OSA in established coronary artery disease are having much better outcomes. So key impact is long-term risk needs to be considered, and CPAP may reduce the cardiac events in patients with severe OSA. There was a study which did not conclusively prove this. There was a controversy around this, but there are other studies which says that the treatment of CPAP in a patient who's already having coronary events results in much better outcomes compared with mortality and morbidity. Similarly, for cardiac arrhythmia, I'm not going to go much into this except saying that patients with OSA have 2 to 4 times higher risk of developing atrial fibrillation. There are hospitals in the Western Hemisphere which screen any patient who's presenting with dysarrhythmia like atrial fibrillation or any other arrhythmic events for sleep apnea. So they have made as a protocol to screen for sleep apnea if any patient is getting admitted or presenting with cardiac arrhythmias. So both bradyarrhythmias and tachyarrhythmias can happen. So the risk of sudden cardiac death increases with the OSA severity. So if the relative risk is 1 in a no OSA, it is almost 4 in a severe OSA patient. Congestive heart failure, again, it's a bidirectional relationship. Sleep apnea and heart failure interact in a complex bidirectional relationship that can create a dangerous cycle of worsening health outcomes. The sleep apnea, because of its nature, intermittent hypoxia, sympathetic activation, oxidative stress, and systemic inflammation, they can cause the heart failure. And heart failure, by its nature of fluid retention, reduced cardiac output, pulmonary edema, nocturnal arousals can cause more sleep apneic events. So this is the mechanisms in which the sleep apnea causes heart failure. The elevated BP increasing the cardiac afterload. Hypoxia induced myocardial stress and increased ventricular wall tension and enhanced ventricular remodeling. Whereas heart failure, because of the fluid shift during recumbency, there is an increased upper airway edema narrowing, increased respiratory drive instability because of heart failure, chain strokes. So then the prolonged circulation time. So how does it affect? The CPAP therapy can improve the ejection fraction by 5 to 10% in heart failure patients with OSA. So in any heart failure patients who are suspecting OSA, please screen them and treat them. There will be a much better outcome. Coming to stroke, OSA, apart from other cardiovascular risk factors like hypertension, atherosclerosis, CAD, like that, sleep apnea significantly increases the stroke risk, even after adjusting for other cardiovascular risk factors. OSA increases stroke risk by 2 to 3 times compared to the general population. So the risk is dose dependent. Higher AHI correlates with increased stroke probability. So the more severe the OSA, more higher the risk for stroke. Both ischemic and hemorrhagic stroke risks are elevated. It is not just one type, it is both types. Pathophysiological mechanisms, again, it's hypertension, endothelial dysfunction, increased platelet activation and fibrinogen levels causing hypercoagulability, and the cardiac arrhythmias, which are potential source of a cardioembolic stroke. So there are clinical evidences which say that there is more than 2.9% increased stroke risk over 4 years. And the Wisconsin sleep cohort, which is one of the longest studied cohort, which was there, which showed that there is a 3 times increased risk of fatal and non-fatal cardiovascular events. And the CPAP treatment reduced the risk for recurrent stroke. So any patient with stroke which we can't identify a proper reason, please think about OSA. So coming from vascular to a metabolic event. Okay, so we have looked at most of cardiovascular and cerebrovascular. So from here, if you can look at the metabolic event, so metabolics wise, there is sleep apnea is promoting insulin resistance, weight gain, and metabolic dysfunction. Again, through the same activation mechanisms like intermittent hypoxia, sympathetic activation, and inflammation. Obesity and sleep apnea, I often tell this to most patients, this is a bidirectional relationship. This is one of the most important things which you have to see. Obesity and sleep apnea. The common thing when we say sleep apnea, so sleep apnea can be a definitive treatment, weight loss. சார் அப்போ நான் வெயிட் குறைக்கிறேன் சார், அது முடியலன்னா அப்புறம் நான் சர்ஜரி பண்ணிக்கிறேன் சார், இல்லைன்னா அதுக்கப்புறம் சிபேப் பண்ணிக்கிறேன், சிபேப் வச்சுக்கிறேன் சார், நான் வேணா அதை ட்ரை பண்ணிட்டு ஒரு 6 months கழிச்சு வரட்டுமா சார்? This is one of the most common answers we get from the patient when we either say you have to go for surgery or when we say we have to go for a CPAP support. So, but as doctors, we should know that there is a clear-cut bidirectional relationship between the obesity and sleep apnea. It creates a self-reinforcing cycle with significant implications. With the obesity, what does it do is there is an increased pharyngeal soft tissue, there is a reduced upper airway muscle tone, which is again decreased lung volume, and there is an increased respiratory workload. Simply speaking, any patient with a neck circumference of more than 17 inches in men or 16 inches in women increases the risk. Whereas OSA, what does it do? There is an altered leptin and ghrelin levels. There is an increased insulin resistance. There is always a daytime fatigue, which reduces the physical activity, and it also dysregulates the hunger signals and increases the cortisol levels. So what does it do? It doesn't allow the obesity to reduce at any level. It only worsens further. So once they get into that cycle, they will think about exercising, but even when they exercise, they can't really reduce weight. So weight loss intervention should be considered as a part of comprehensive OSA treatment, agreed. But CPAP therapy will improve the metabolic parameters facilitating weight loss. So we need to consider either a bariatric surgery or CPAP before we can really push them for a weight loss intervention. Right. So 70% of OSA patients are overweight or obese. Just imagine 70%. So there could be around 20 to 30% of patients who are non-obese, but they still could have OSA. So when we said again, each 10% weight gain increases the OSA risk by almost 30%, and each 10% weight loss will reduce the AHI by 20 to 50%. Similarly, the diabetes, again, OSA and diabetes have a bidirectional relationship. Sleep apnea is an independent risk factor for developing type 2 diabetes, and OSA is present in 60 to 80% of people with type 2 diabetes. Severity of OSA correlates with poor glycemic control. Key mechanisms of insulin resistance, I will come back to same: intermittent hypoxia, sleep fragmentation, which disrupts the glucose metabolism and hormone regulation, systemic inflammation, which increases the TNF-alpha, IL-6 and CRP levels, causing again problematic glucose metabolism, and altered adipokine levels, like the increased leptin and decreased adiponectin, which increases the insulin resistance. What is the impact on glycemic control? It increases the fasting glucose, increases the HbA1c, increases the insulin resistance, and decreases the insulin sensitivity. When we treat with CPAP, the meta-analysis show that CPAP therapy can improve insulin sensitivity, glycemic variability, and long-term glycemic control with good response to diabetic medications. So metabolic syndrome, like we have seen obesity and diabetes, so we have to come to metabolic syndrome. Obstructive sleep apnea promotes a cascade of physiological changes that contribute to development of metabolic syndrome. What are the pathophysiological mechanism? Same: intermittent hypoxia, sleep fragmentation, and sympathetic activation. Clinical significance: almost 70% of OSA patients have metabolic syndrome versus 24% in general population. Cardiovascular risk is a 5-fold risk in cardiovascular disease when both conditions, when both metabolic syndrome and OSA are present. CPAP, by improving the insulin sensitivity, may improve the metabolic parameters. So by dyslipidemia, there is an effect of sleep apnea on lipid metabolism, which causes increased triglyceride levels, increased LDL levels, decreased HDL levels, and increased ApoB or ApoA1 ratio, right? So and CPAP therapy has again shown to improve the lipid profiles, particularly triglycerides and HDL levels, after 3 to 6 months of continuous use. In the interest of time, I'm not going to go into the finer details. The OSA and atherogenesis, again, the sleep apnea worsens the atherosclerosis through dyslipidemia and other mechanisms like accelerated plaque formation, increased LDL and decreased HDL, along with the endothelial dysfunction. And the patients with sleep apnea have higher coronary calcium scores also. So now let's come to the third section. Probably, sir, probably I will exceed by around 5 to 7 minutes. The neurological and cognitive impacts. The sleep apnea also affects the brain function, memory, concentration, and the mental health. So what happens in this? There is an excessive daytime sleepiness. This is the primary symptom of sleep apnea affecting 50 to 70% patients, caused by sleep fragmentation and intermittent hypoxia, measured by Epworth sleep scale and other sleep scales. Scores more than 10 indicate excessive sleepiness. The cognitive domains affected are attention, reduced vigilance and sustained attention, executive function, impaired problem solving and decision making. The processing speed is much slower, memory deficits occur. So functionally, it results in poor academic score and poor productivity in work. What happens in real life? There is an accident risk, 2 to 3 times a higher risk of motor vehicle accidents. The work performance, 35% reduction in work productivity, and there is a equivalent to a 5-year aging effect on cognitive testing. So the cognitive deficits are often reversible with effective sleep apnea treatment. So, and even the daytime sleepiness, of course. So we need to think about treating in any patients who are having cognitive domains which are unrelated or looks excessive for their age. Coming to the mood disorders, the sleep apnea can cause depression, with the OSA people having 2.6 times more likely to develop clinical depression. Again, it is a bidirectional relationship. The depression can worsen sleep apnea and sleep apnea can worsen depression. So mechanism is because of chronic sleep fragmentation. Because of chronic sleep fragmentation, even when they sleep, they are perceived to have slept for a long time. Their sleep is not complete, not quality of sleep is very poor. So because of hypoxia, there is an altered neurotransmitter function which causes depression. The anxiety and panic attacks can be there. That nocturnal choking and getting up can create panic attacks, and that awakenings can really be a problematic thing. And post-traumatic stress disorder, in patient with the pre-existing trauma, sleep apnea can worsen the symptoms. So what we need to do is, when we treat them properly, they improve the mood. So it's not just neurological, it's also psychiatric. So many patients with OSA report clinically significant psychiatric symptoms. The risk correlation, yes, severity of OSA has a depression risk increasing. And even there is an untreated OSA which may increase the suicidal ideation twofold. So screening for mood disorders should be standard practice in OSA patients. Any patient in OSA, we should screen for mood disorders, and we should avoid any of this suicidal tendencies or any of the other psychiatric symptoms should be properly addressed too. When it comes to children or even in adults, the cognitive domains get affected and the memory is also affected. Both the working memory and long-term memory are affected because of sleep apnea, procedural learning and spatial memory as well. The underlying mechanisms again is the same: sleep fragmentation, intermittent hypoxia, and altered sleep architecture. There are MRI studies which show the reduced gray matter in hippocampus, which is a critical memory structure. The radiologist here will be much more knowledgeable in this than us. And academic performance may decrease even up to 50% in students with OSA. And the CPAP shows a partial reversal of memory deficits after 3 to 6 months. So, but the problem is, in memory impairment may persist despite adequate treatment in long-standing severe cases of sleep apnea. So how does it affect the quality of life? These are certain things which I already looked. So the work performance is reduced. Driving safety, like even the Chernobyl accident, which is a nuclear disaster accident, which was supposed to be not a terrorist thing, it is only because of a sleep apnea. But no one knows the truth exactly, but this is supposed to be. So the driving safety concerns up to 40% slower response to road hazards. We have had many patients who have come to us after a road traffic accident only to discover that the road traffic accident occurred because of sleep apnea, not anything else. So the accident risk is 2 to 7 times more. Annual economic cost in US, it exceeds more than 86 billion in lost productivity, 50% higher rate of workplace injuries, and ESS or Epworth sleep scale more than 10 strongly correlates with the functional impairment, which requires a definite intervention. So again, it has a social relationship angle also. There is an impact on intimate relationship. Obviously, because of the snoring, the bed partners will not be very enthused. to there are up to 40% of couples resort to sleeping in separate bedrooms, and reduced libido, erectile dysfunction, decreased relationship satisfaction also form a part because of the OSA. The social functioning, there is a social withdrawal because of the fatigue and impaired communication and stigma. They won't be able to go with others in a group trip because they are embarrassed about snoring, and people don't take kindly to CPAP use in public. So all this happens. So then the work relationship and the career impact also is a part of the problem. So the motor vehicle accidents, which you already discussed, and workplace accidents, and even the household accidents may be there. And all this accident risk is more in more severe OSA. Mild compared with moderate is more, moderate compared with mild is more, and severe compared with moderate is much higher. So the CPAP treatment or any treatment with CPAP for sleep apnea will reduce the accident risk by almost 3/4, with significant improvements seen just within 2% of, 2 weeks of consistent therapy. So screening of commercial drivers and high-risk occupation can prevent fatalities and reduce economic burden. So the last part, the other systemic complications beyond cardiovascular and multiple metabolic effects and the respiratory effects, sleep apnea can affect multiple other body systems also. So there is a relationship between the OSA and immune function, OSA and hormonal changes, and OSA and cancer association. I think I have covered the whole of general medicine when I say sleep, but that's how important. There are enough studies to show that all this is all study proven data, which I've just filtered all the details, and I just put the basic facts before you. So again, it's basically chronic intermittent hypoxia, sleep fragmentation, and sympathetic activation. There is an increased susceptibility to upper respiratory infections in these patients. Higher rates of pneumonia and higher rates of COVID-19 were seen in OSA patients. Complications like slower wound healing and recovery from illness and the reduced vaccine effectiveness were seen in certain studies. Biomarker changes were like pro-inflammatory cytokines like IL-6, C-reactive protein, TNF-alpha, neutrophil to lymphocyte ratio, and oxidative stress markers were all increased in OSA patients compared with the normal population having the same set of diseases. So the CPAP treatment may reverse many immune abnormalities when used consistently. So the hormonal and endocrine changes, as we discussed earlier, there is a decreased levels of testosterone in men with OSA, independent of age and obesity. There is an erectile dysfunction, which is much more common in men with sleep apnea. There is a disturbed diurnal pattern and of the cortisol, and there is a elevated evening levels. So catecholamines results in the evening levels are increased, and there is an increased sympathetic nervous system activity. The PCOD is associated with again OSA. Fertility rates are reduced both in men and women with untreated sleep apnea. So growth hormones also are suppressed nocturnal during fragmented sleep. So these are all part of vicious cycle. They may actually worsen the sleep apnea severity, creating a self-perpetuating cycle, which we need to break at some point. So CPAP therapy has shown to normalize the testosterone levels in men after 3 months. So screening any of patients with unexplained hormonal disturbances, consider sleep apnea. So there is other evidences which are again emerging with the concerned with cancer. So there is a population studies which show increased cancer incidence with patients with OSA. These are all not completely proven data, but there are confounding factors and heterogeneity in studies and limited prospective data. But there is evidence is not high, but it's only moderate, growing, but needs further validation. So more research is needed to establish causality and determine if OSA treatment modifies the cancer risk also. There are certain cancers which have been shown to associate with OSA, but not everything. So when it comes to treatment, I'm not going to touch. I think I'll skip this for the want of time, and two, my fellow speakers are going to treat more on this. So there are other, like apart from CPAP, there are other treatment like oral appliances, postural therapy, which Dr. Dhanashekhar will be speaking, and surgical options, Dr. Vijay will be speaking. So I'll just quickly skip this. I will just say there are certain prevention and management strategies like lifestyle interventions, there are medical approaches, there are surgical options. For this, we need to comprehensively sleep evaluate and risk stratify and comorbidity assessment. First line therapy selection should be properly selected, and whichever therapy is selected, they need to ensure that the adherence is monitored and properly intervened and regularly followed up. So there is a multi-system impact of sleep apnea. Sleep apnea is associated with serious cardiovascular, metabolic, and neurological consequences that significantly increases the morbidity and mortality. Early intervention, like timely diagnosis and treatment, can reverse or significantly mitigate many complications, especially cardiovascular and metabolic risks. Treatment efficacy, CPAP therapy, and other interventions have shown a strong evidence for improving quality of life and reducing complication risks across these systems. This is a silent epidemic with up to 80% of cases remaining undiagnosed. Sleep apnea represents a major unaddressed public health concern with the increasing obesity in India, which can cause a substantial economic burden in the years to come. So we need to screen the high-risk population systematically, like any patient with obesity, any patient with resistant hypertension, any patient with type 2 diabetes, monitor, and we need to diagnose. And in this regard, the general practitioners are going to see the major chunk of cases. So you need to be aware that there is a disease like this which can cause a variable impact on multiple things. So like seeing a patient with hypertension and seeing a patient with stroke are different. All of you would agree. Seeing a patient with diabetes and seeing a patient with cardiac failure is different, both for you and for the patient. The risks associated and the lifestyle affected in both cardiac failure and stroke are much higher and much more expensive. So it's in your hands whether to diagnose them early and make sure that they don't get into the consequences and complications of sleep apnea. So we need to incorporate patient education and long-term consequences to improve the treatment compliances. So the call to action here is early recognition and management of sleep apnea should be prioritized in clinical practice to reduce the substantial burden of associated complications and patient outcomes. So thanks once again from the Institute of Lung Care Group. We are a 4-doctor group with Dr. Unithan sir, Dr. Srikanth sir, and myself and Dr. Nagarajan sir.
Yes, sir.
Let me stop here.
Yes, sir. Thank you, sir. Thank you very much, sir. It was an extensive, but considering the length of the topic, it was a very brief introduction to all the doctors who are participating in the CME, sir. And any questions from the audience can be taken up now itself, sir, or for the answer?
Whichever way you would like to.
Okay, sir. So any questions you can be find one of the questions, sir. Can I ask you, sir?
Yeah.
Yeah. See, considering the polysomnography and the sleep study.
Sir, I'm not able to hear you clearly, sir. Sorry.
Considering the polysomnographic, the gold standard is PSG, polysomnography. Considering polysomnography and home-based sleep study. So you told 90 to 100% sensitivity in polysomnography and 90 to 90%. Like legally, will it be answerable if the patient is treated based on home-based sleep study compared to PSG?
No, ideally, everyone should undergo a polysomnograph, lab-based polysomnograph. But what is happening in reality is the technology is slowly overtaking, and AI is one of the few areas where sleep studies are coming in. The scoring is getting much better comparatively with a few years back, and current scoring is much better. So even home scoring, home sleep studies are internationally or in American ASM criteria, if you take, they go only with lab-based studies. They don't advocate home sleep studies earlier years. Now, even there, they have been started with home sleep studies. So we can go ahead if the patient is having a cusp of a problem, or there is a other factors which need to be factored in, then it's better to go for a lab-based study.
Yes, sir. There's a question people all who snore should we be afraid? There is a question from the doctor.
Sir, I'm sorry. I didn't get you again.
Should snoring be feared for? Is a simple way of asking this question, sir. People are
Snoring be
afraid of it or not? He is asking.
Snoring to be feared.
Yes, sir.
Oh.
Or snoring should be feared or not?
Snoring should be feared if the patient is having other problems, particularly if the patient is having a diabetes or hypertension and that person is snoring, I would actually fear.
Yes, sir.
So,
Yes, sir. And then there are questions regarding management, sir. Like when we proceed with the management, we'll ask those questions, sir.
Sir?
The management, there are questions regarding management, sir. Let all speakers
let them complete the.
Yes, sir. That will be better, sir. Yes, sir.
Yes, sir.
Thank you for the short introduction. Thank you for your presentation, sir. Now I request our next speaker for the day, Dr. Anand Raju, sir. Sir, are you online, sir?
Yeah. So, able to hear me?
Yes, sir. Yeah, we are able to hear you, sir. A short introduction, Anand sir is famous in ENT field, but he's new to the IMA CGP platform. So I give a short CV of Anand sir. So he's the chairman and managing director of Anand ENT Hospitals at Coimbatore, and he's also head of department of ENT at College Hospitals, Radio Road, Chennai. He's a pioneer not only in sleep surgeries, and he's international faculty in sleep surgeries, and he's also faculty. He's international faculty in cochlear implant for he has done more than 500 cochlear implants, and he's also faculty for cochlear implant in PhD hospitals of Coimbatore. So this is a very short introduction. You will understand after his talk, like anything, how he is capable of. Sir, your stage is yours, sir. You can, sir. Please.
So I just going to share my slides.
Yes, sir. Please.
Able to see my slides?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Yeah. I don't know my voice is clear or not, but so
proceed, sir. No problem, sir.
Yeah. So Dr. Nandagopal actually covered everything. It's a more extensive talk actually. So I'm going to talk about only how we going to approach sleep apnea. It's a comprehensive approach to evaluating obstetric sleep apnea. So the today agenda is actually, first of all, I want to thank you, Anand Sokalingam, as well as Sendil Kumar, for this wonderful chance to give a talk in the platform. Thank you so much for AMA Tamil Nadu. Thank you. The agenda is what is the burden of OSA? Clinical suspicion and history taking a OSA patient. This is very, very important, my perspective. Clinical examination and then investigation. And art of counseling. So we are a sleep surgeon, so we have to counsel the patient for sleep surgery. So the art of counseling to OSA patient is very important. Then multidisciplinary approach to treatment for OSA. Then what is the future for OSA treatment? So the burden of OSA, before going into the talk, I want to play this video. Anand, able to hear the video? Able to?
The sound is not audible, sir.
Video sound, no?
Yes, sir.
Now it will come.
Even though we only see the video.
No, the lady is trying to cure his husband sleep apnea. She's trying a lot of innovative technique. Then finally, she's trying some newer method. So she's happy. But actually, she failed in his newer technique. That's why sleep apnea is a social problem. So a lot of people are coming for social disturbances, not for a health issue nowadays, actually. So young couple, actually, after the marriage, they're coming for a sleep apnea solution. Actually, they're not coming for the health issue. They're coming for sleep disturbances as well as social. So any grinder machining actually is running next to the partner. Nobody can sleep, actually. That's why there's a lot of people are coming for looking for some social solution for these social disturbances. It's a common and prevalence in our population. Already, actually, Dr. Nandagopal discussed about everything about this. More than 40% of the adult population snore. Snoring can lead to serious medical conditions. So, extensive talk by Professor Nandagopal. So, as children, actually, we are seeing a lot of pediatric, this thing. Nandagopal is prominently seeing a lot of adult patients. We are seeing a lot of pediatric OSA. The prevalence is 1 to 3%. Sleep disorder breathing in adults aged 30 to 60 years is around 24% in men as well as 9% in women. A lot of people are coming for surgery, even the female gender, they are coming for surgery. So 4% of male and 2% of female is mild OSA. Moderate is actually 2% of males and severe OSA is 0.3% in male, but it's a old data. Nowadays, maybe the data may be increased. So the classification is primary snoring, otherwise upper airway resistance syndrome and obstructive sleep apnea syndrome. So a lot of people are coming for mild snoring. So there are habitual snoring whenever they're tired, as well as the sleep cycle and REM sleep, they used to snore. There'll be no obstruction. There's a primary snoring. Upper airway resistance syndrome. So this is a table. Actually, clearly we can differentiate between what is the primary snoring, what is happening in primary snoring, and upper airway resistance syndrome and obstructive sleep apnea syndrome. The respiratory distress index is actually less than 5 per hour in primary snoring. In oxygen desaturation is always always saturation is more than 90%. Daytime sleepiness won't be there. In upper airway resistance syndrome, RDA is less than 5 and saturation actually is more or equal to 90% or more than 90% of saturation. Daytime sleepiness may be there. But in obstructive sleep apnea, there is actually RDA respiratory index is more than 5 per hour. Saturation always less than 90. So daytime sleepiness is more in obstructive sleep apnea. So with this small table, we can differentiate what is actually severe obstructive sleep apnea, what is upper airway resistance syndrome. Apnea is already discussed actually, cessation of airflow at the nostril or mouth at least for 10 seconds. What is sleep apnea syndrome? 30 or more apneic episode during 7-hour periods of sleep is sleep apneic syndrome. So central sleep apnea is actually no airflow at the nose and mouth, associated with cessation of all respiratory effort. But in obstructive sleep apnea, there is continuous respiratory effort will be there. They used to struggle for breathing. So there will be respiratory effort will be there. In central sleep apnea, there will be no respiratory effort. Mixed apnea, there will be combination of both central and sleep apnea. Central obstructive apnea is a normal unobstructed airway. This is snoring. Normally, snoring is actually palatal flutter. It's a vibration of oropharyngeal musculature. So, for high airflow, they produce vibration of this thing. That's the sound because of the vibration. This is a complete obstructed airway. So, the tongue actually, as well as the palate, is actually falling backward and complete obstruct the airway. So, this is as a ENT surgeon, we are looking for obstructed airway. So mainly it's upper airway, maybe in the nose or maybe in the nasopharynx or maybe in the oropharynx or maybe below the oropharynx, maybe retrolingual or maybe the epiglottis level also. So mild, we used to tell 5 to 50 apneas per hour. Is a more than 15 to 30 apneas per hour is moderate. Is a more than 30 apneas per hour is actually severe. So the problem is actually it's a serious problem. So it increases the daily day-to-day activities and produce obesity and depression, anxiety, and road traffic accident. So we have a lot of solution for this. There's a surgical correction as well as conservative non-surgical treatment, weight loss, alcohol avoidance, sleeping on one side, and pharmacological therapies are there. The nasal CPAP, so combined CPAP is there. So we have a lot of solutions. But actually, how to approach this sleep apnea patient, whether we are treating a real obstruction or we are treating only the simple cold or maybe primary snorer. The clinical suspicion history taking is very important in OSA patient. So the screening is very, very important actually. So always you ask question to the partner. So the patient itself actually they can give a symptom like this. I can have a headache or early morning sleepiness, actually increasing weight, not able to concentrate. But you ask the partner whether it's the choking is there or not actually. The patient, they can't give any clear history about the choking. Only the partner, they can know whether the husband is choking complete. There is no breathing in between actually. So they already, Dr. Nandagopal discussed about the elbow, this thing. They used to stimulate the patient to start the breathing. So ask the partner whether there is a choking, is a real obstruction, or maybe this is full snoring. So clinical suspicion history taking is actually, so we have to ask a series of questions. One is what is about excessive daytime sleepiness? And if there is any headache and poor concentration and memory, mood change, irritability, so obesity, increased weight, even though there is a less diet, and witness apnea or gasping, choking during sleep. And noxuria is very common. This thing they used to get up for so urination for very frequently. So the excessive daytime sleepiness is one of the commonest this thing actually they're not able to concentrate in work, actually not able to concentrate in driving. So we would ask about this. Then risk factor is so obesity, whenever there's a nest circumference is more than 18 inches in men, 16 in women. Male genders actually there is more predominantly they have OSA, age is above 40. Then craniofacial abnormalities and family history of OSA, then excessive use of alcohol or some sedative drugs actually, smoking, hypothyroidism, all these risk factors you have to ask the patient. So before going into the whether treatment actually. So key components of history is actually you have to ask the sleep history, sleep duration, whether they have a very good sleep for 7 hours and quality of sleep and bedtime and wake time during. So night awakening and causes, partner reports of snoring and apnea. This is very important. Then medical history, ask about hypertension, whether actually there is no family is a hypertension, but the patient used to have a very high BP. Then ask about cardiovascular disease, any alteration in the palpitations, heart rate and diabetes mellitus and GERD and hypothyroidism. Then ask about family history. There's a family history of OAC also very important. And substance use, alcohol, sedative. A lot of patients actually because of the insomnia they use sedatives. The sedatives they then sometimes produce a relaxation of muscle tone. They can produce snoring. Occupation, especially the safety sensitive. Daytime functioning actually ask about sleepiness. So driving performance and work performance and academic performance and if there is any work related accident, all you have to ask in history. Then coming into the clinical examination, as a ENT surgeon, we used to examine the nose, throat, and actually larynx, all we used to examine. But as actually physical examination, ask about obesity, whether the BMI is very less or high, enlarge neck circumferences, and look for the facial abnormalities. If there is any facial abnormalities, so we have to get an opinion from our dental colleagues also, crowded upper airway, constricted maxilla, and hypertension, and retronadia, residual actually retracted mandible, nasal obstruction, and decreased oxygen saturation. All these have to elevate. Then obesity, already discussed about the BMI. Then the craniofacial abnormalities, glossomegaly. A lot of people they have a huge tongue. Actually, Down syndrome, you know that the tongue as well as length as well as the diameter of the tongue is actually very high. Enlarged tonsil, Mullenberg classification, and lateral narrowing, and retronatia, nasal congestion, or any deviated septum or polyps, and neck circumferences, neck mass, or car deviated is all you have to look for physical examination. The nose already discussed. Actually, this is the part. Actually, this huge tonsil is a grade 4 tonsil. See, the tongue is also the diameter is very high. A lot of fat deposits in the tongue, as well as the elongated uvula. So, along with the elongated soft palate. So, all these are actually we go to look for any upper airway obstruction. Then adenotonsillar hypertrophy in pediatric sleep apnea, neuromuscular hypotonia, and craniofacial neurological symptoms. All we go to assess before going into the treatment. Then coming into the investigation part. So investigation, so routine investigation, so you do actually, but these questions are very important actually. The stop bank questionnaire, we ask actually, we have a form. So whenever the patient comes for snoring treatment, we will ask them to fill the form actually. So stop bank questionnaire is very important questionnaire. It's developed by anesthetist for actually there's a preoperative assessment purpose. But nowadays we are using for our sleep apnea assessment. So this S for snoring, T for tiredness, O for observed apnea, how much apnea they used to have during the throughout the sleep, then high blood pressure. Then so there's a BMI. BMI is more than 35 is very significant, and then age more than 40 or more than 50. The neck circumference is more than 40 centimeter, around or maybe 17 more than 17 inches. Then male gender. These are actually positive these things. So we would assess this questionnaire whether before going into whether it's assess whether it's a mild OSA or moderate OSA or maybe severe OSA. Then it's a very important questionnaire is fourth sleepiness scale. How likely are you dozed off in the following situation? So sitting and reading. So they used to, you know that actually they used to read the paper automatically. They used to doze off. Then watching television. Then sitting inactive in public spaces. Lying down to rest in afternoon when circumstances permit. Sitting and talking to someone. sitting quietly after lunch without alcohol, as a passenger in a car or in the flight for an hour without any break, in a car while stop for a few minutes in traffic. So this is very common actually. A lot of people are coming and saying actually in the traffic signal almost I'm sleeping. So these are the common questionnaires. So we ask the severity of OSA. So there's a grade is 0, 1, 2, 3 like this. Actually number of total scores more than 10, definitely they have a severe OSA. Then polysomnography, so the another sleep study. So normally we used to do so for so assessment of severity of sleep apnea is a gold standard. So in sleep apnea, the records actually we used to record EEG. So the pulmonologists they can talk about very clearly about this EEG, then ECG, then electrooculagram, then electromyography. All they used to read. I don't know how so relevant to ENT surgeon, all these actually, but definitely is relevant to assess some sleep disorder, actually, maybe restless syndrome, insomnia, or something else. So these factors are very important for a ENT surgeon. Pulse oximetry, so saturation dip, nasal and oral airflow, episode apnea and hypopnea, and sleep position, whether they in supine position or in prone position or maybe lateral position, how severe the apnea, hypopnea, then what is the blood pressure and what is the esophageal pressure, all they used to assess in polysomnography. Then for as a ENT surgeon to assess the upper airway collapse, this is a very important tool. So whether a selection of the patient for maybe non-surgical management or maybe positional therapy or maybe myofunctional therapy or maybe surgical therapy, we used to stimulate the patient. We used to stimulate the sleep with a Dexmed or maybe fentanyl or propofol with a metered controlled infusion. We stimulate normal sleep, but you know that actually we can't stimulate REM sleep. Only we are seeing the non-REM sleep actually during sleep. So we can assess the upper airway, how much the airway is behaving to our sleep. So this is one of the drug into sleep endoscopy video. It's a lady, see the labored breathing. So this abdominal push is there. So now she's struggling for breathing, but there is no actually apnea. She's breathing. So this is a fiber optic endoscopic assessment. We used to pass the nasopharyngeal scope or maybe flexible scope inside the nose, and we assess the nasopharynx. So and we assess the velum, then we assess the hypopharynx. In this patient, actually see the epiglottis. The epiglottis is itself is causing collapse, as well as the above, the lateral collapse by the tonsil. Then little above, anteroposterior collapse by the palate. And in the velum area, there's a circumferential collapse, as well as a lateral collapse, as well as the anteroposterior collapse. Once you go down, we are able to see the prominent lymphoid follicle and the tongue base. And see the epiglottis itself causing complete collapse. So we are giving a jaw thrust. So the patient actually is improving. Only now the anteroposterior collapse is gone. Only there is a mild lateral collapse. Even though the lateral collapse is not significant, the patient is able to breathe. Definitely, this patient will improve with the mandibular advancement devices actually. During this drug-induced sleep endoscopy, we will ask the patient to turn one side and we will assess whether in the positional therapy also will improve the sleep quality. Suppose even the positional therapy is improve the sleep quality, definitely we'll ask the patient to sleep one side and do exercise and do the weight reduction, definitely they will improve. Now after the release, actually complete collapse, see the saturation is falling down. So this patient actually, so they can go for the mandibular advancement device. Otherwise, they suppose they want surgery, so we will stage the surgery, maybe nose and we after the nose, so the throat, the palate and tongue, even tonsil, everything actually. So this is the observation window and events during drug-induced sleep endoscopy. So normally we do a drug-induced sleep endoscopy for 15 to 20 minutes. So patient does not respond to verbal stimuli. This is a stage of actually normal stimuli. So this BIS monitor, suppose a lot of, so our sleep surgeon, they have a BIS monitor. The normal score is 80 and 50 is normal score. In this score, actually the patient is used to sleep normally. Then introduce the endoscope slowly and begin observation. Slowly start from nose and the nasopharynx and the palate and go in the velum area. Observe upper airway just below the choana, see the palate and how it collapses. then observe the tongue base and epiglottis will collapse actually. Give us now. Don't do a regular level within 5 to 10 minutes actually. Observe for 1 to 2 minutes in each area. Then at least do a regular sleep endoscopy for 20 minutes. The drugs what we are using is a drug-induced sleep endoscopy is a dexmedetomidine. So actually it's a very safe drug. Actually half-life is very fast. Actually don't produce any respiratory depression. We can use a propofol as well as we can use a fentanyl as well as we can use a midazolam. Midazolam is a very strong acting. Actually sometimes the respiratory depression is very high. In midazolam in larger doses we can get a REM sleep, but it's very dangerous. So the dose also very important. Actually suppose you give a high dose, the sedation is very high, the collapse is also very high. That's why this drug-induced sleep endoscopy is slowly, you need a learning curve. So in the learning curve, you can assess each part of the upper airway and how it behaves during our sleep. Maybe it's anterior-posterior collapse, or maybe lateral collapse, or circumferential collapse. According to the finding, you can design a surgical modality. Then auto counseling as a OSA patient. Actually, this is very, very important actually. So as a ENT surgeon, so we used to focus sleep surgery. So sometime actually we will ask them to go for a CPAP. A lot of our pulmonary colleagues actually, suppose they think it's upper airway obstruction, they used to send the patient to assess the drug-induced sleep endoscopy, and we will use to give a recorded video to the pulmonologist actually. The other way can decide whether the patient may go for a CPAP or they can, so they can benefit with the sleep surgery. So you have to ask the patient, so whether there is any nasal obstruction or excessive dry.
Anand sir. Anand sir, you're not audible. Anand sir. Okay. 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 கொஞ்சம் ஸ்லோவா போவேன். Having some problem with the connectivity. He's uploading, so kindly be online.
Anand?
விஜய், ஆனந்த் கனெக்டிவிட்டி நெட் ப்ராப்ளம் இருக்குங்கிறாரு.
Okay, if there is any questions in between, we can discuss about the diagnosis till now.
Outcome of surgeries for OSA, is it better in male or female patients? There is a question.
See, the gender is not a major issue in an outcome analysis. Because the hormone, as per the study, the hormones plays a role. At the same time, there are studies which disproves that also.
Yeah.
And females till their menopause, the hormonal factors help them to prevent OSAs. So that favors the hormonal theory. At the same time, even obese woman
slides.
has
Okay. No.
got it online. So gender doesn't have much a bigger factor for assessing the outcome of surgical outcome.
Okay. Thank you, Jay. Now Anand sir is online. Anand sir online, sir, please.
Please.
Sorry for my internet instability. So, yeah, the art of counseling for a patient for surgery is very, very important for us ENT surgeon. But we can't force them to go for a surgery. So we will give a choice actually. So some patient comes to ENT surgeon. So after the CPAP usage, you know that now the 40% of patients actually they have a non-complaints of CPAP. This already they use CPAP for at least 1 or 2 years. They used to come after for actually for another better solution to ENT surgeon. We will discuss the patient whether actually you want a surgery really, and we will assess the upper airway and we will assess the palatal airway and we will assess the tongue base, and we will tell them actually so whether you have to go for a drug-induced sleep endoscopy. After drug-induced sleep endoscopy with the video, we will discuss the patient. So these are the obstruction you have. Definitely you can benefit with this surgery. Otherwise, suppose you don't want a surgery, definitely you can go for a mandibular advancement devices or you can go for a CPAP. Sometimes actually it's a huge tongue base as well as the epiglottis collapse. They can't actually go with the CPAP. Even CPAP, they actually worsen the situation. At time, actually, definitely we have to advise a surgery for them actually. Then we have to assess the actually ask the expectation from the patient. We can give a assurance whether your snoring definitely go, obstruction definitely will go, but obstruction definitely will go. The snoring won't go. Even I snore. Even my partner will snore. Everyone can snore enduring actually sometime in very relaxed position or maybe excessive tiredness or something. Sometimes actually we used to snore. So we have to ask the patient, you want 100% snoring relief? Definitely we can't give. So we can give a relief from obstruction. Definitely we can improve your quality of life. Definitely, so you can improve your work performance and definitely you can improve your so sexual life. Everything we can improve after surgery, but sometimes actually the snoring may persist even after surgery. So these are the counseling question as well as discussion before going into the management as well as before going to the surgery is really needed. This art of counseling is very important with the OSA patient. Then part so 6 actually multidisciplinary approach to the treatment. So already we discussed this is a non-surgical treatment. So to avoid use of alcohol in the evening, so you discuss with the patient about the dietary management. So suppose the weight is actually very high, so you'll ask them to go for exercise, join a gym, and keep a trainer and maintain reduce the weight as well as avoid unnecessary fatty food as well as unnecessary take of alcohol. Everything you have to discuss with the patient actually before going into the main treatment. Then smoking should be avoided and reduction of weight is helpful. Positional therapy is definitely actually useful. So suppose patient actually they can't sleep in only one position. I used to advise my patient actually keep a pillow behind and tie the pillow with a belt and sleep in one position. Definitely you actually won't turn during night actually. Otherwise they keep a ball. The ball is okay, but sometimes they feel actually pain during this thing. As well as a lot of sleep pillows are available now online. They can buy from online. They can sleep with the sleep pillow. Definitely the position therapy definitely help them to control this sleep apnea as well as the heavy snoring. Then coming into the intraoral devices, we can actually judge whether patient really needed this thing. So mandibular advancement devices and tongue retaining devices, and they help to improve and abolish the snoring. This MAD actually we used to call MAD. So this we will ask our dental colleagues to step in inside. Actually, we will ask them to design the mandibular advancement devices. Now a lot of mandibular advancement devices are available in online also. The only problem is they can produce a lot of irritation, sometimes actually gingival ulceration, so they can't tolerate the mandibular advancement devices. Then myofunctional therapy, nowadays actually even after surgery we were advancing this myofunctional therapy. Myofunctional therapy is a therapy we increase the tone of the tongue musculature as well as the palatal musculature. There are a lot of actually therapies are there. We will ask the patient to pull the tongue out as well as lateral and right side, left side, and pull the buccal mucosa with the pressure and ballooning of the balloon. as well as rotate the tongue and swiping the hard palate. So this all the structure will improve the musculature of the tongue as well as the musculature of the soft palate to reduce the relaxity of the palatal muscle to improve the snoring. Then finally coming to the surgical part, so CPAP is the wonderful device. Actually, suppose they are happy with the CPAP, we will ask them to go with the CPAP. Suppose they are not happy with the CPAP, so we will ask them to come for a second sitting and discuss with a surgical option, and we will advise some surgeries, palatal, soft palatal surgeries, or with some bony surgeries. You know that already we discussed, so 40% of the patients find the use of CPAP device cumbersome and difficult to carry with them whenever they're traveling outside or maybe abroad. So surgery, the goal of surgical correction in the upper airway is to reduce the number and severity of obstructive events, not a complete snoring. Since most OSA patients have multi-level disease, including nasal and palate and retrolingual obstruction, the appropriate surgical treatment should be multi-level. So there is two options. So Dr. Vijay is going to talk about the surgical option. I'm not going into the detail. The single stage and multi-stage is there. Single stage, we'll do everything in a single stage. Multi-stage, we will divide the nasal part first and the oral part and palatal part second. The level, so nose, oropharynx and hypopharynx, lot of actually surgeries are there. So Dr. Vijay is going to talk about the surgery. The simple one is a septoplasty, turbinate reduction, tonsillectomy, palatoplasty, and tongue-based reduction. These are the surgeries are available to approach this sleep apnea patient. This is a surgical algorithm for obstructive sleep apnea. It's an updated Stanford sleep surgery algorithm. Normally, we used to take a history. In history and polysomnography, suppose BMI is very high, we will ask them to go for a bariatric surgery. Then we do the imaging or drug-induced sleep endoscopy. According to the drug-induced sleep endoscopy or maybe imaging, we'll ask them to go for a CPAP or maybe come for the surgery, nasal part, soft palate part, tongue, and then total upper airway. So maxillary mandibular advancement. This give a 80% improvement in snoring. So this is a modified, updated Stanford sleep this thing. So this is a comparison of various surgical procedure. So Dr. Vijay is going to talk about this. Only surgery is give a 100% cure as a tracheostomy. We do a tracheostomy, it's a 100% cure. But we can't give tracheostomy for all the patients. But some patients, BMI is very high, more than 40, weight is more than 145 kg. No other option, we have to do a tracheostomy. Ask them to go for a weight reduction and bariatric surgery, then come with the second sitting, we take out the tracheostomy and close the tracheostomy wound. This is also happened. So I did one not to tracheostomy for a OSA patient. Then future perspectives is actually this hypoglossal nerve stimulation. So this is actually results are very promising. So for a tongue-based collapse, this is one of the wonderful situation method. The stimulated device, this is the device that sends electrical impulse to the nerve and regulates your tongue movement. Stimulation electrode, this is the wire that connects to your nerve. Then pressure sense electrode in the chest, actually, the sensor detector breathing. If there is any abnormal breathing collapse, it will give a signal to the nerve, and it nerve signal to the muscle, and the muscle will pull the tongue up, actually, then anteriorly, it will increase the retrolingual space. Thank you so much. This is my talk about comprehensive approach. So Dr. Dhanashekhar as well as Dr. Vijay is going to talk about extensively about medical management, surgical management. Thank you so much for this wonderful opportunity to give a talk in the platform. Thank you.
Yes, sir. Thank you, Anand, sir. Sir, there are a few questions to be taken, sir.
Okay.
Number one, the significance and the gold standard is polysomnography. And introduced the new term like DICE, drug-induced sleep endoscopy. And being a physician, he is considering PSG to be as the gold standard. Being a surgeon, from your perspective, will you do both for the surgery for a patient, or will you add something like a radiological illustration, like a sleep MRI, to the armamentarium to come to a conclusion of treatment?
Actually, there's even though diagnostic sleep endoscopy, actually, normally what we believe actually is one of the investigation of choice for sleep apnea surgery. But polysomnography, we going to do for all the patients. So it's actually not only detect the obstructive sleep apnea, so we can find out where all other type of sleep disorder. So sometimes, so we will miss some other sleep disorder, maybe central sleep apnea. Sometimes we will miss it. So with this polysomnography, definitely we can pick actually this really obstructive episode or something else actually. So if really obstructed episode, suppose the patient wants to plan a surgery, then we will plan drug-induced sleep endoscopy. Otherwise, we'll ask them to go with the CPAP for at least 1 or 2 months, as well as we give a CPAP titration. So suppose the patient is happy with the CPAP, definitely we will ask them to go with the CPAP. So for the patient age is more than 65, actually the BMI is not very high. Definitely we will ask them to go with the CPAP first. Go to the pulmonologist and get a CPAP first. And actually the CPAP is young age. So a lot of actually the recently married people, they can't sleep with a CPAP. So they won't actually go for a CPAP mission. They will come for a sleep surgery. So at that type of patient, the BMI is very less. So promising upper airway obstruction, definitely we will advise them to go for a this thing. Sleep MRI, I am not prescribing sleep MRI, but Dr. Vijay is actually used to prescribe sleep MRI routinely for all his patients. Sleep MRI, a lot of patients actually, they won't sleep properly in the sleep MRI machine actually because of the huge sound. Even though obstructive patient, they can sleep in any sound area, but sometime actually I don't think so. My opinion, it won't give a proper result. But this is also one of the very interesting, very promising investigation of choice for locate which areas promising obstruction. But sleep endoscopy directly in your vision, you are seeing so the dynamic collapse of the area. So whether it's anteroposterior, how the muscles are behaving. With the sleep endoscopy, we can do a lot of exercise. Like we can put a nasopharyngeal tube and we can relieve the soft palate obstruction. We can ask the patient to turn one side. We can assess the positional therapy whether it really improves or not. We can pull the jaw first and then we can patient will benefit with the mandibular advancement devices or not. These are the positional therapy as well. These are the procedure possible in drug-induced sleep endoscopy, not possible in sleep MRI. That's why my opinion is, so actually before going to any major procedure, I do a sleep endoscopy. This is my investigation of choice for my patients.
Yes, sir. So you take a polysomnography, and if the patient is, depending upon the age of the patient, you ask them to do the 3 month CPAP and titrate whether he is improving in his symptoms or not. If not, you subject him to DICE and decide the level of obstruction to proceed with the surgery. Yes.
Yeah. Yeah.
So that is the gist to take home messages. Like first was PSG, the audience today, they find out, they know what is the gold standard, like polysomnography. And as I said, from the surgeon's point of view, the second thing from the second speaker is DICE. And the first speaker, he emphasized on PSG, and the second speaker, he is emphasized on DICE. But what he is very particular is, first, he subjects the patient depending upon the age to undergo the CPAP and titrate whether he is improving or not. Then only he goes in for a surgical procedure if necessary. So this is the take-home message until now from the second speaker. Thank you, Anand sir. Thank you for the elaborate and very short review, sir. Thank you very much, sir.
Thank you so much. Thank you.
So now we call upon the next speaker of the day, Diagnostic, sir. He's and he is also interested in sleep medicine. See, the gist you would have understood by now. This seminar was planned in such a way that there should be 2 surgeons and 2 pulmonologists in this, so that you will understand like all cases are not subject to surgery by an ENT surgeon. Some may be thinking in that way, and all cases are not being prescribed CPAP by the respiratory physicians. So it's a collective treatment method modality where the take-home message should be this. Now, Professor Gansey sir is going to talk about management strategies in sleep apnea. Sir, your slides are visible, sir. You can, sir, start, sir.
Yes, sir. Thank you so much, sir. Thank you so much for the IME for giving me this opportunity. With this, I'll start with the previous 2 speakers who have talked about. Dr. Andagopal has talked about the complications of obstructive sleep apnea, and Anand sir has talked about how to assess the patient with obstructive sleep apnea, what are the histories you have to take. Now I am going directly into the talk on management strategies on obstructive sleep apnea. This is going to be a one minute, sir. There was a delay. now I'm going to talk to you about the management strategies in obstructive sleep.
The slideshow, sir, it is.
Yes, sir. It is in the slideshow only, sir. Able to see, sir? No?
Yes, sir, we can see, sir, but your other slides are seen as on the side itself. So you don't see the single slide as the full screen.
1 minute, sir. Now, sir?
Now it's also the same, sir.
1 minute.
Definitely, if you can change the next slide, sir, we'll see whether we are able to read or not, sir, then. Now it is okay, sir.
Sir. Able to see now, sir?
Yes, sir. You can see, sir, your
Yes, sir.
audible, sir.
A few words about obstructive sleep apnea is which affects around 1 billion people worldwide, and which is a major health economic burden in our in the entire world. As we all know, our Prime Minister has recently talked in the Monkey Path about the obesity and reduce 10% of the oil use, so that you can reduce the cost of the reduce the obesity in our community, and thereby decrease the economic burden of the country. And currently, OSA is basically diagnosed by polysomnography. As all of us showed, there is a level. Polysomnography is a level 1 study. We have level 1, level 2, level 3, and level 4. Level 1 is a full-fledged polysomnography in an in-lab study, whereas is a level 2 is a polysomnography at home without any supervision. Level 3 and level 4 are only cardiac and respiratory monitoring will be there, whereas the level 4 or the watches as well as the app-based devices are called as level 4 devices. But the gold standard is a polysomnography. But what will be after doing the polysomnography? It will give you a lot of data, which a physician have at least to go through in detail. But what we see objectively finally is what is the sleepiness, what is the quality of life of the sleep, and finally we decide by whether the patient is having an obstructive sleep apnea or not by a single number. It is called as an apnea hypopnea index, and sometimes we may use a oxygen desaturation index. With that, we'll diagnose obstructive sleep apnea. Once you diagnose an obstructive sleep apnea, what are the treatment options available? Now, most of the time, these patients will be put on CPAP as one size, one fit approach to the treatment and with less personalized care. But nowadays, the pattern has changed where we have an endotypes and phenotypes in obstructive sleep apnea, which we have in asthma and COPD, where it's an eosinophilic type or a non-eosinophilic type of COPD. The same thing, we are also having a phenotypes and endotypes in obstructive sleep apnea, which recent studies have suggested that it is a heterogeneous disease. And by both the mechanism, what is an endotype is which will show the underlying mechanism by which the obstructive sleep apnea is there. What is a clinical expression is a phenotype. I will give you an example in later part of my talk. And what is obstructive sleep apnea? You can see from the single slide, you can see if you have an absence of during sleep, there will be a muscle decompensation will be there, pharyngeal muscle activity will be reduced, and there will be a collapsibility of the upper airway. So because of the upper airway collapse, the patient gets apnea. So they will have hypoxia and hypercapnia. Once they go in for an apnea, there will be again, it will be stimulated by the brain, and micro awakening will be there, and the pharyngeal muscles get open. So because of this sleep fragmentation and excessive diurnal drowsiness, which leads to most of the complications in obstructive sleep apnea. And so everybody knows about Kumbhakarna, the old myth about the sleep. So in this, we can find out what is the endotype in this case and what is the phenotype in this case. Mainly the endotype is the mechanism. What is the mechanism in this case? Because of the obesity, the pharyngeal adipose tissue got enlarged, so there will be a airway narrowing by the upper airway narrowing will be there, and there will be snoring. So upper airway narrowing is the endotype. What is the phenotype? Excessive daytime sleepiness is one of the phenotype, and obesity is one of the phenotype. So clinical expression is called as a phenotype, whereas the mechanism is called as an endotype. With this, we have a lot of endotypes and phenotypes, by which the personalized treatment modalities will vary for each patient. Previously, we have a one-fit approach for all the patients, but now we have each endotype and each phenotype, we have a different approach and different in the management strategies. So here I'll give you a small introduction about how the endotype may guide in your management. If they have a mild obstructive airway collapse, if the positive airway pressure is less than 8, and you can go for an oral appliances or a hypoglossal nerve stimulation and weight loss if indicated. So if you have a mild OSA, the positive airway pressure is required is less than 8, you can go for an oral appliances or hypoglossal nerve stimulation. If the severe airway collapsibility is there, if the BMI is less than 25, you can go, if the airway abnormality is obvious, then you can go for a surgical management. If overweight and obesity is there, you can go for a weight reduction management and positive airway pressure. And if the patient is having a ventilatory control instability, that is a central sleep apnea is there, then he is not a candidate for a hypoglossal nerve stimulation, and you have to go for a BiPAP in this type of cases. And if there is a low aerosol threshold is there, if the AHI fraction is high and positive airway pressure by CPAP or a BiPAP is a treatment of choice along with the hypnotics. So with the endotypes, you can how will you select in the management will be given in this slide. So you have a different phenotypes. You have a clinical phenotype, pathophysiological phenotype, you have a biological phenotype, and an environmental phenotype. In an environmental phenotype, you have a sleep pattern. Some people who now in Chennai, it is more common, where most of them are doing their full night duties, and they will work for USA. So they will be full day, they will be doing the night, they will be working, and the daytime they will be sleeping. In that type, it's called as a sleep pattern type of phenotype, where if the patient is an alcoholic, if the patient is an obesity, that is one of the different phenotypes. Clinical phenotypes, what you will have, the patient is having an age phenotype, if the patient is very old, then they are more prone to develop obstructive sleep apnea. If the patient is a sex-wise, if the patient is a male, they are more prone to develop obstructive sleep apnea. And the polysomnographic pattern-wise, if they have a REM, non-REM based sleep apnea, that is called as that is also one of the phenotypes. Whereas in case of a physiological phenotype, if we have a ventilatory drive or an upper airway anatomical defect, or a muscle responsiveness is poor, then each one has a different phenotypes. And you have a biological phenotype where if you have an oxidative stress or endothelial dysfunction or a fibrinolytic imbalance or an inflammatory, these are all different types of, there are markers which are responsible like IL-6 and IL-10. These are the biological phenotypes you should know about. So each phenotypes and endotypes have a different stage or set of management, and it depends upon it will give you a personalized management strategies. How the phenotype by guiding your management, if they have an excessive daytime sleepiness, if they have a difficulty in sleep, if the AHI is more than 5, and there is a mild obstructive sleep apnea by home-based sleep study, you can go for consider a polysomnography, full-fledged polysomnography in this case. If the patient sometimes the AHI will be more than 15, the patient may be asymptomatic. In that type of case, the physician is the one who can decide on the management, whether the weight reduction or you have a positional therapy will guide in the management. That is a phenotype based in the management. So here I am given the different endotypes. What is the endotype here? Is an enlarged tonsil. What will be your management? You remove the tonsil. If there is an obesity, you do a weight loss. These are the mechanisms. This is an endotype which is causing the obstructive sleep apnea, and you have an elevated loop gain and a low dilator muscle weakness will be there. And this is a different phenotype. In that case, you could give a supplemental oxygen, they will be benefitable. What are the phenotypes? If they have a severe excessive daytime sleepiness, and in this case, you have to treat according to they are more prone to develop cardiovascular risk in this type of patients who are having a frequent fragmented sleep and recurrent hypoxia, leading on to severe cardiovascular risk in this type of phenotypic patients. And obstructive sleep apnea endotype, you can classify into an anatomical compromise, impaired pharyngeal dilator muscle function, that is mainly by the loop gain and unstable ventilatory control, that's an elevated loop gain, low arousal threshold, that is also one of the different endotypes that is responsible for the obstructive sleep apnea. If the patient is very obese, if the patient is having a moderate to severe obstructive sleep apnea with an AHA of more than 30, and most of the time it will be a 65% will be males and rest of them will be females. And in this type, it decreases the tone of the upper airway dilator muscle, especially the genioglossus is a key contributor for the obstructive sleep apnea pathogen. So this is the basic physiologic type, whereas the anatomical type is because of the obesity, airway narrowing, and physiologically because of the decrease in the tone of the upper airway dilator muscles, leading on to obstructive sleep apnea. Sometimes you may have a craniofacial morphology. If the Mallampati score is 3 or 4 or a retrognathia, all these patients, this is a basic anatomical defect, and you can have a different types of clinical management where you can have a high and low respiratory threshold, respiratory arousal thresholds, and ventilatory control instability, where in case of a hypercapnic or hypoxic respiratory failure will be there in this type of patients. So what is a low arousal threshold? What is a high arousal threshold? They are low arousal, low arousal threshold, they are more prone to wake up from sleep and more likely to have mild to moderate obstructive sleep apnea, whereas the high arousal threshold, they are predominantly associated with severe obstructive sleep apnea. And in low arousal threshold patients, sedatives will be helpful, but in case of a high arousal threshold, the sedatives will be more harmful for the patient. Associated with less hypoxia in patients with a low arousal threshold, whereas in high arousal threshold, they are more prone to chronic hypoxia and they are more prone to severe apnea, sleep fragmentation, and more complications. So these are the different phenotypes, endotypes you may have to. Whether or the OSA endotypes is going to help in your management strategies? Yes. How it is going to help if the patient is having a endotype? Individualized therapy will help in the management of each patient. Each endotype will have a different management strategies, which I have shown you previously. And some patients may go for a surgical management, some patients may benefit from obstructive CPAP or a BiPAP in the management. What are the obstructive sleep apnea phenotypes? As I told, the sex, age, ethnicity will also be more common in males, 2 to 3 times more common in males than females, and more males will have a severe oxygen desaturation index will be more in males than in females, and anatomically males are more prone to develop obstructive sleep apnea by the increase in the fat deposition along the pharyngeal airway muscles. And as I told you, in elderly patients who are having an obstructive sleep apnea, any patients who are above the age of 65, already they will have a reduced airway caliber. That way, they are more prone to develop obstructive sleep apnea. And there are some studies found that decrease with the age, their airway collapsibility will decrease with the age, collapse easier, increased deposition of the pharyngeal fat, increased pharyngeal collapsibility during sleep will cause obstructive sleep apnea in patients with elderly phenotype. And OSA, as I told, OSA in REM sleep and non-REM sleep. Hypopneas and apneas are known to be longer in duration, and cause increase in the severity of hypoxemia during REM compared with the non-REM type of phenotypes. So the prevalence of REM-related OSA ranges from 10 to 36% of the patient population with OSA undergoing polysomnography. And REM-related OSAs have been found to be associated with the risk of hypertension. And OSA in a menopausal woman, this is one of the phenotype. And menopause, pregnancy, and polycystic ovarian disease increase the risk of OSA in patients, OSA in this type of patients. And after menopause, the worsening of severity OSA is predominantly occurred during the non-REM sleep, whereas than the REM-associated OSA. And supine related OSAs, most of the time, obstructive sleep apnea is more common in supine position, and 20 to 60% of the patients will get snoring as well as apneas during the supine position. That is also one of the type of phenotype, clinical phenotype. In this type of patients, if you put the patient in the lateral position or by the use of devices, that is awakening devices, that will help in the management of this position-related phenotypes. So there is a changing in the spectrum in the management. If you have a pathophysiological type or a clinical presentation type or a biological type, the management is going to be different. Anatomical compromise will be there. And in clinical phenotype, you will have an excessive daytime sleepiness, insomnia, mood disturbance, and minimal symptomatic. Biomarkers type, you will have a hypoxic burden will be there, which is a predominant. And comorbidities, you have a cardiometabolic or a neurocognitive symptoms will be there. So there is a changing in the spectrum in the management of obstructive sleep apnea. And most of the time, we have to classify what is the endotype of the patient, what is the phenotype of the patient. And according to that, you have to manage. Most of these obstructive sleep apnea patients will go to different different specialties, especially the cardiology, urology, pulmonology, neurology, ENT, endocrinology. Most of the patients who are having uncontrolled diabetes, and there's patients who are on a lot of obese patients, we have to rule out obstructive sleep apnea in this patient. In patients with cardiology, most commonly these patients will have a uncontrolled hypertension. They will have 2 to 3 pills for control of their BP, or sometimes they will have a ventricular fibrillations or atrial fibrillations, and sometimes you can see a sudden cardiac death. We have one patient who went for a sudden cardiac death during this study in the polysomnography room, and retrospectively we had a very difficult time in our mortality committee, where we have to take all the data, how the patient went in for a sudden cardiac death. So these patients are more prone to develop sudden cardiac death. So as you should have which patient has to be referred, and which why the patient is having a lot of problems, you have to send for obstructive sleep apnea by doing a polysomnography treatment. Coming to the management of obstructive sleep apnea, I'll go into fast. Weight reduction is a main aim in the management of obstructive sleep apnea, and the manipulations and body positions, as Sir was talking about, sleep ball technique, sleep sock technique, and gravity sensitive position monitoring alarms are there, so that the patient can sleep in the lateral position. There are few pharmacological treatment like protropion, nasal decongestions, nasal blocks, by using a topical steroids will help in the management. Oxygen therapy, where the patients with obstructive sleep apnea going in for severe oxygen resuscitation, these patients are more can give with oxygen therapy. This is a position therapy device. This will, once a patient sleep this side, it will vibrate, so the patient will automatically sleep in the lateral aspect. This is a position sensor alarm, so that will help the patient to sleep in the lateral position. And there are certain drugs like modafinil, armodafinil, which is marketed in India already. This will help when sometimes if you have a complex obstructive sleep apnea. These are the drugs that will help in the management of obstructive sleep apnea. These are the other two drugs like pitolisant and solriamfetol are the latest drugs which are not marketed in India. It is in the study position, and these are the gold standard management of obstructive sleep apnea is a CPAP and BiPAP. What is CPAP? CPAP will give you a constant pressure. If the patient requires a 10, the patient will get a 10 pressure. What is a BiPAP is you can select the inspiratory pressure and expiratory pressure. You can give an inspiratory pressure of 14 and an expiratory pressure of 6. In this, the patient will be more comfortable. Some patients who needs a high pressure, BiPAP will be of helpful. And those patients who are having an obstructive airway disease or a parenchymal lung disease, in that type of patients, you rather go for a BiPAP than a CPAP. So these are the two different things you have to think. Whether CPAP acceptance is mainly based on the cost factor, because most of the time it's very costly, and the mask factor or an interface factor is also one which are the thing we have to keep in mind. So manual CPAP is one where you have a constant pressure, you have an auto CPAP. If the patient is in the supine position, it will be in 10. Suddenly turns to the lateral position. If the patient needs, if the pressure need is 5, automatically the auto CPAP will change to 5. That is the difference between an auto CPAP and normal manual CPAP. And these are the different these are the different masks that's useful in the maintenance thing. This is a nasal mask, and this is called as a dreamwear mask, where you have the top end you can see here. This is rotatable. This tube will go into the back of the pillow, so the patients are more comfortable with this type of mask. And this is a full face mask. This is a gel mask, which is less damage to the skin. And this is a nasal mask. And this is a full face magnetic mask. So this magnetic mask is helpful because the patient can remove on their own. They don't need to depend on the other patient, other people at home. And this is a same like a dreamwear mask. It's an N30I mask. This is also the same thing. You have a rotating tube in the back, so the patient will be more comfortable. And these are the different. This is a pillow mask. And this is a hybrid mask where you can, hybrid magnetic mask is available. This is a full face mask. And there is a different thing how the CPAP compliance can be improved. Patient education is must. CPAP treatment optimization is must. Mask, that is what I told you, is an interface, humidification, and telemonitoring. And my specialty in this talk, I'll go talk about the telemonitoring. What is telemonitoring? Telemonitoring increases a CPAP adherence by 72% in the first 90 days. What is this telemonitoring? This contains an AirView or a MyAir app, or you can use both. What we follow in my clinic is both the AirView and MyAir has been followed. I'll show you how we do the remote monitoring is helpful. And it's a two-way communication. Once a patient uses, switch off the machine, the data will be transferred to us. We can monitor the pressure from here. We can find out the air leak. We can ask the patient to tighten the mask. And you can adjust the pressure from my clinic to the patient, whether the patient in US or Singapore or any part of the world. You can change the pressure from your clinic itself. That is the one advantage of remote monitoring. This is a cloud-based device, and this is mostly helpful for the physician as well as the home care providers who can access the data. And this is how the data will look like. See, the patient name will be there, how much the patient used, whether the patient has used, whether the patient has a air leak is there or not. And these are the different icons available in AirView. If the patient is compliant, it will be green. If the patient is non-compliant, it will be red. If the patient is having an air leak, you can see the yellow color at the bottom. If the patient is having a high AHI, you can see the yellow color at the top end of the this icon. So you can see the high AHI. If the device is not used, it will be empty. If there is a monitoring is done, but the data is not received, it will be like M. So if the patient is using more than 4 hours, then it is a compliance is met. If the patient is not using CPAP for less than 4 hours, then the compliance is not good. That will be in the red into. And these are the patient names. If you have any, this is a good compliance, the patient has used for more than 4 hours. This is a bad compliance, the patient has used less than 4 hours. You have a more air leak is there, but the patient is having a good compliance in this case. So these are the bad complaints and the good complaints. So this is the part why I'm going to lively, I'm going into my clinic device. So you can see how we see the patients. I'm going to log in. So I have logged in now. So you can see the patient data. So now I'm going into the wireless mode. So I have all my more than 70 to 80 of my patients will be there in this AirView app. You can see here, I'll go to one patient. This is a Krishnamurthy. Yes, this is a patient with a 140 kg weight male, and he is using very well. And you can see the 93% is a percentage he has used, and he has around good complaints. He has used more than 4 hours, but the yellow color sign is there. So the patient is having an air leak. So my clinic people will call the patient and find out whether your mask is not tight. So you have to keep the mask properly. So now I go to the patient data. So this is how the patient data will be. And you can see what is the patient is using. This is a good complaints. You can see here the patient has used less than 4 hours, 3 hours, 56 minutes. So it has shown as a good, bad complaint. Anything above 4 is called as a good complaints. And you can remotely assess the patient. You can see the patient details. See here, I'm going to the patient details. Data of the patient, from where the patient is, and from where who is my technician who has given the devices. And you can go for the prescription wise. And going into the prescription, now the patient is very obese and the patient is needing a high pressure. So this patient was in a was given a BiPAP. So the patient is in 16 IPAP, and ramp is set is 15 and EPAP is 6. So if I want to change the prescription now, I can change the prescription.
That's it. Your screen is not moving, I think. It is there in the same Institute of Sleep Medicine slide itself.
Oh, okay, sir. I think it's lively not communicating, sir. Live is not seen, sir, now.
Yes, sir. Not, sir. You are seeing only that Summa Institute of Sleep Medicine slide, sir.
Oh, this is not shared, sir.
Yes, sir. Yes, sir.
Okay, sir. I think I'm going on live from that slide. I'm opening into each data. I think it is not, I don't know what is the problem there. I'll check, sir. 1 minute, sir. I'll check. The live of live of live. Yeah. See. Share பண்ண So now you can see, sir. So now you can see, sir.
See, sir.
Yes, sir. So this is a patient is kept on 16 and 6 is a EPAP. So now if I want to change the setting in the card, I can change the setting. And now the patient is having a 16. And if I want to change the by remote assist, so edit the device setting. So now I am going to edit the device setting. I think you are able to see sir now. So now I'm going from 16. Now I'm going to increase the pressure to I'm increasing to 17. Okay. Now I have kept it 17 as IPAP and EPAP as 6. So once I set this, and then if I save the setting. Automatically, the machine gets saved. Once the patient starts using that, he will have an IPAP of 17 and EPAP of 6. So this is one of the major breakthrough in the telemonitoring device. And if you want to get the data of 1 month also, you can get the data. So create a report. You can select the data, both the compliance and therapy report, and you can fix that time period for the last 30 days, continue, you will get the fixed report. Now the compliance report is ready. The patient has used properly and the patient has used 28 days, 93% positive, and you will get all the data will be there. What is the C? What is the IPAP which has been kept? What is the EPAP which has been kept? How many hours the patient has used? And what is the air leak level? And what is the pressure monitoring? You can see initially I started with 20. Then I slightly gradually I'm reducing the IPAP. So this is how you can adjust from here so that the patient will be of very helpful for the patient. So this is the whole therapy thing. I'll go to the share. So this is how this telemonitoring works. So this is this I told you that the therapy report and usage data will be there, leak will be there, pressure data will be there, AHS will be there, and you can have the compliance over 30 days average. All these things can be seen by the telemonitoring, and this is a telemonitoring app along with the telemonitoring device. And this will help you in the management. With this, the patient compliance will be better by the use of both the app as well as the devices. So I'll quickly move on to the next level of management. There is a nasopharyngeal stents are available. So you can see here the stents, which will be useful, but it is very risky for the patient. It will be more inconvenient for the patient. Most of the time, it's a failure. And you have these are the stents which has been placed, and these are the expiratory nasal resistors. This is available in Amazon, but this is also not going to helpful. Without EPAP, you have the collapsibility of the airway. You have with the EPAP, you have an positive pressures will be created, and thereby opens the airway. This is one of the valve mechanism used. And these are the EPAP devices available. This is an oral pressure device. This will be kept over the tongue. It will give a negative pressure and sucks the tongue back so that the airway won't collapse. So this is a oral pressure therapy device. And hypoglossal nerve stimulation, which is fastly increasing in the usage. But you will have like a pacemaker, one soft tissue lesion, one instrument will be there so that it will generate the. And this hypoglossal nerve stimulation is also based on different endotypes, and not for all the cases will be helpful. These are the oral appliances, which are there are a lot of oral appliances available, and I have seen a lot of patients using, but it is also one of the failure because it can be used for mild obstructive sleep apnea, for moderate and severe, and I don't think oral appliance is going to be much useful for the patients. And these are the different oral devices. And you have this is one of the exercise that is available to improve the upper airway muscles, and this is also one of the helpful. And this is a myofunctional therapy. Thereby, this is also one of the thing that will help in the improvement of the muscle strength. And these are the surgical procedure. I think Dr. Krishna Sir will be giving you a detail about that. I have it depends upon the selection of the patient is more important in surgery, because this patient who has done a surgery after 2 years again came to me with severe obstructive sleep apnea, and we have to put the patient back on CPAP. So selection of cases is more important, and and those who mainly the surgeons who are interested in this specialty will be a better option for this selective type of upper surgical procedures. So coming to the conclusion, upper airway is obstructive sleep apnea is a heterogeneous disease, both in terms of pathogenesis, that is endotype, as well as in expression, that's a phenotype. The mechanism underlying OSA may be an important in determining the response to clinical interventions like nasal CPAP. Clinical presentation of OSA is highly variable, with some patients maybe asymptomatic, others will have a major cardiac vascular risk. And there are further researches going into the OSA endotype, phenotype, and in genetics in obstructive sleep apnea. And the gold standard with this, I'll close this talk. And gold standard diagnosis is by in-lab polysomnography, and the gold standard in the management depends upon the endotype and phenotypes in obstructive sleep apnea. Thank you, sir. Thank you for giving me this opportunity.
Thank you for your brief insight and comprehensive evaluation and medical management of sleep apnea, sir. I think many of the CPAP machine can be titrated online by the participating doctor, so that
Sir, your voice is not clear, sir.
So it was a new insight, I think, sir. There is one question: when to refer to a pulmonologist, when to refer to an ENT surgeon from one Dr. Arun Stalin?
It's a different, it depends upon, as I told you, sir, most of the time you have to do clinically assess the patient, do a polysomnography. After that, if the patient is having a tonsil or adenoid, you refer to the ENT patients. Sometimes if the patient is having a dynamic airway collapse, in case if you do a circumferential airway collapse in patients, in these by doing a DICE, if you find out, these patients may be helpful by surgery. Most of the time, CPAP will be the gold standard in the management of obstructive sleep apnea.
Yes, sir. Yes, sir. Thank you, sir. Thank you for your very elaborate talk, sir. Thank you very much, sir. Now we'll go on to the next topic for the day, which is by Dr. Vijay Krishnan. Professor Vijay Krishnan is the head of Department of Snoring and Sleep Disorders at Madras Singh Research Foundation, Chennai. He is also the president of Indian Association of Sleep Apnea Surgeons, and he is a scientific committee member of the World Sleep Society, and he is a co-chair of the Cervical Sleep Society 2026. Vijay Krishnan, Professor Vijay Krishnan is going to extensively talk on the surgical management of sleep apnea, which will be the final talk of the day. Vijay Krishnan?
Good evening. Can you hear?
Possible, sir. Yeah. Yes, sir.
Good evening, one and all. At the outset, I would like to thank Dr. Anand Suklingam and Dr. Senthil and the entire IMA team for arranging this wonderful CME week, and that OSA is being selected, and it definitely it is an interesting topic for for everyone, as we are coming across so many OSA patients in our daily practice, even in among our relatives. I'm sure the three stocks which was already covered, the entire spectrum of OSA is being discussed about how they present, what are the consequences, and how we have been evaluating these patients and how we can manage non-surgically. So the next part of the discussion is going to be about how this patients can be managed surgically. As an ENT surgeon, I would like to share our experience on this particular topic. So we all know that obstructive sleep apnea is a common disease of both adult and pediatric age group with myriad of presentation. As the previous speakers were describing, it is a spectrum of disorder and a metabolic syndrome. It could be just a primary snoring or it could be a severe OSAS. So the diagnosis and management of this patient is a specialized and challenging area, and involves many specialists from many disciplines. That's why this one topic is being discussed among a group of different specialty people, like IMA meeting, and going to be discussed. And there are so many factors which I'm straight away getting into the topic of surgery, right? So the most important thing as a surgeon to know is when not to operate, when not to do surgery for this patient. And the couple of factors in which the obesity plays a major role as part of OSA itself, and also when you select your patient for surgery. Whenever the BMI is more than 35 to 40, it is you have to be really cautious, or maybe even not to do any kind of OSA surgeries in these patients, as the results are not promising, because there are so many factors in this obstructive sleep apnea syndrome. You know that syndrome. It is not just an upper airway obstruction. At the same time, if the BMI is between 25 and 30, or maybe 35, you can do surgery, but with a lot of precautions. And other important thing to know is to know other sleep disorders, which are kind of a differential diagnosis of OSA. That's where the role of PSG is very important. We can't just like that do a drug-induced sleep endoscopy and do surgery, because there are so many other sleep disorders which has to be ruled out, like insomnia, narcolepsy, especially the central sleep apnea, which will mimic like obstructive sleep apnea. Hypothyroidism, simple hypothyroidism. The patient will be saying obese and snoring, daytime sleepiness, all may be there, and upper airway resistance syndrome and restless leg syndrome, etc. There are so many, but these are the common things which we come across, and we have to choose rightly, identify these patients and refer these patients. So after a complete clinical examination of nose and throat, I'm sure Dr. Anand has explained clearly. But as a surgeon, before putting a knife on the patient, we have to know the type of OSAs. We know the severity of OSAs with the polysomnogram, but we have to know the type of OSAs. That is the component of static and dynamic obstruction. That's what Dr. Dhanashekar, previous speaker, told me. When you just look at the throat and if you see huge adenoids and tonsils, refer the patient to ENT. It's like that. So you have to identify whether before even referring to ENT, you yourself can examine the patient, whether the patient has any gross septal deviation, or huge tonsils and adenoids, or the bone, maxilla or mandible is pushed posteriorly, or retromagnathism is there. So these kind of things you can identify in your clinical setup itself. So this relation of airway to the bone and soft tissue is very important. There are three structures. Remember, there is a box, there is a skeletal framework, and there is an orange color is an airway, which is in the center, and surrounded by soft tissue, fat, and muscles. So when the bony compartment becomes smaller, that also compresses the airway. At the same time, the soft tissue is getting thickened because of obesity and muscular hypertrophy. The soft tissue compresses the airway. In both the scenarios, the airway is being compromised. And it is much more severe in obese hydrognathics. You have to keep these things in mind. So the component of static obstruction is always present. The obstruction worsens during sleep, but it is always present. But the dynamic obstruction present only during sleep, when muscle tone reduces, when the patient gets into sleep. Especially the soft palate and tongue base collapses, and sometimes epiglottis also collapses during sleep. But most of the time, both exist together, the static obstruction and dynamic obstruction. So the component of static obstruction, for example, patient Mr. X may be having 75% of static obstruction and 25% of dynamic obstruction. He may be a good candidate for surgery, but patient Y may be having 25% of static obstruction and 75% of dynamic obstruction, which may not be a good candidate for surgery. As Dr. Dhanashekar said, uh, uh, so many, so this is kind of example, prognathism and retrognathism, and the gross septal deviation, different types of deviation of nasal dorsum. I'm not talking about the septum, the nose itself, you can obviously see. These are all external diagnoses which can be picked up even without looking inside the nose. These kind of gross septal deviations. Sometimes the inside anti-rhinoscopy may be able to diagnose huge obstructive turbinates, hypertrophy, or deviated nasal septum, or nasal polyps, etc. So these are also part of static obstruction. and adenoid hypertrophy and tonsil hypertrophy. It is not just common in pediatric age group. Nowadays, we see a lot of adult patients and adolescent patients with obstructive adenoids and tonsils. So the next step, I think Dr. Anand clearly explained to you about how these awake studies and dynamic studies are being done. So awake studies like lateral cephalometry and so many other simple cone beam CT, airway analysis, all these examine the static factors that predispose these patients, whether the patient may have an obstructive apnea or not. But there are certain dynamic studies during sleep provides insight into the state-dependent anatomical physiological changes that happens in the airway. That means the drug-induced sleep endoscopy, dynamic MRI. These two dynamic studies are commonly being done, but this has to be done during sleep so that we will know what is happening inside the upper airway. So dynamic MRI, the patient sleep, that's a natural sleep in the MRI gantry. It's a balanced force-field echo sequence, and turbo-field echo modes are used to create these lakhs and lakhs of cine MR images and put together into a small video clip where you will be able to identify where the obstruction is happening. So this is a small snapshot of that to see the difference between a dynamic MRI of a normal patient and a sleep apnea patient. You can nicely see how thick and edematous and long palate and uvula, and how the fats are being deposited in the tongue and the nape of neck and the submental region and surrounding the upper airway. So all these are causing obstruction. This is a video clip where you can measure the length of the soft palate, thickness of the posterior airway, be, behind the palate, behind the tongue base, how the epiglottis. So all this can be measured in a video format where you can, it is just a non-invasive technique, but as he rightly said, some 5 to 10% of the patient, maybe 20% of the patient will not be able to properly sleep in the MRI gantry because of the sound, maybe because of the claustrophobia, or sometimes morbidly obese patient even cannot enter into the MRI gantry. But this is very safe and effective procedure to diagnose different patterns of obstructive sleep apnea. This is a dynamic MRI of a patient where you can see huge adenoids blocking the passage. Otherwise, the soft palate is a little bit edematous and adequate posterior airway space there behind the soft palate and tongue base, and you can also see the epiglottis. So I'm not going to go in detail about dynamic MRI and dyes as it has been already discussed. So the dyes, this clip shows a circumferential collapse, which is blocking the upper airway. That is, this is happening behind the palate. So there are various treatment options, has been beautifully discussed earlier. But the key to understand is it is a multidisciplinary treatment approach is important because it is a complex disorder. Tailored therapy is needed for an individual patient. It cannot be like one size, one fit for everyone. Some patient may need a CPAP, some patient may need a surgery, some patient may need both. So that's what we have to keep in mind. So what is the role of ENT surgeon? It isn't, we all know that this is an upper airway obstruction, but this is not just upper airway obstruction alone. So airway anatomy evaluation is most important in these patients, and that's what we can do with a flexible laser pharyngoscopy or drug-induced sleep endoscopy. And also in identifying candidates for surgery, whether this patient fit for surgery or can we do any surgery in this patient, or oral appliance therapy will be effective, or why the problem with CPAP. We can do drug-induced sleep endoscopy along with CPAP to see why the patient is not able to tolerate CPAP. Whether this patient, we can do drug-induced sleep endoscopy along with oral appliance to see the effectiveness of oral appliance. So all this can be done by the ENT surgeon. So it is like a holistic approach, and it should be a patient-centered approach only to improve the patient's morbidity. So let us come to the surgical treatment. So the basic principle of OSA surgery is the objective is to alleviate the obstruction, not only the obstruction and the associated cardiovascular and neurobehavioral sequelae. CPAP is usually the first line treatment, no doubt about it. But at the same time, the aim and goal is to improve the quality of life, not to give CPAP to every patient. Another important factor to understand and recognize that multiple levels of airway obstruction exist in OSAs. Must treat all levels of obstruction in an organized and safe manner. This is where the failure happened in the early period of 1970s and 80s and maybe 90s. because every patient was treated thinking that palate is the obstructive area and palatal surgery is being done. But that's not so. The multi-level obstruction is there and that has to be observed. Rec- And the more nowadays it is more towards reconstructive surgery rather than a destructive surgery. No butchers, we are not going to be butchers. So this is the original Stanford protocol where the level of 3 levels of obstructions being identified with the physical examination, cephalometric analysis, and fiber optic pharyngoscopy. At that time, there was no drug-induced sleep endoscopy. It's Muller's maneuver where they just pass the endoscopy and ask the patient to take a deep breath and blow against the and take deep breath. So by that comparison, they will know where the obstruction is happening. So accordingly, they have divided level 1, 2, and 3. And level 1, just a palatal obstruction where type 1 oropharyngeal surgery, UPP is where being performed. Type 2 is both obstruction of palate and tongue base was happening. That's where UPP along with genoglossal advancements being done. And type 3 is pure retrognathal obstruction or retroglossal obstruction where genoglossal advancement surgery with higher myotomy is being done. If that is phase 1. After 6 months, if the patient has persistent symptom, confirm it with the PSG, and if we name it as failure, then there is a phase 2 surgery called maxillomandibular osteotomy is being performed, which can give up to 80 to 90% success rate. At the same time, it has been revised. Now, this revised protocol also being discussed earlier. Here, the most important thing to see here is even in after drug-induced sleep endoscopy and clinical examination, if you think this patient will not improve by phase 1 surgery like palatal surgery, tongue-based surgery, etc., we can go directly to mandibular advancement surgery, where that is considered phase 2 surgery. And sometimes you have to see here how we have accepted maxillomandibular advancement. After that, may go for PAP therapy, or even after PAP therapy, maxillomandibular advancement can be done. So this 2A is most important point, I would say, to understand that it is a multidisciplinary approach, and it's not just one way or other way. So understanding that multi-level collapse of upper airway is very important, and most common is more than 90%. And there is a combination of velopharynx and oropharynx or velopharynx and hypopharynx, etc. So the combination of nasal static obstruction and upper airway dynamic obstruction can also be there. So correcting the septal deviation and turbinate hypertrophy along with correcting the dynamic obstruction by palate and tongue base is very important. So another important thing to remember is single stage versus multiple stage management. That means that all depends upon the patient's complaints, patient's understanding about the disease, and surgeon's expertise and the facilities available in the hospital. So single stage means you can do multi-level collapse in one single stage, like nasal surgery, palatal surgery, tongue-based surgery, everything in single stage, and monitor the patient in the hospital for a couple of days, and then discharge the patient and evaluate them. Multiple stage means you can do surgeries, nasal surgery first, and then palatal surgery, and then tongue-based surgery, or depending on various combinations. That depends upon how your expertise and how your team is expertise to manage the complications if it arises. So patient selection is very crucial. The patient's component is also very important because if the patient is having so much of comorbidity, it may be very difficult to do a multi-level collapse as a single stage. So counseling is very important. Talk to your patient, explain why this is happening, what are the options available, explain both CPAP and surgery and other modalities of treatment, and if needed, other sleep medicine specialist counseling or sleep medicine specialist evaluation and discussion. And everything has to be properly explained to the patient so that the patient has been given all the options and choices to choose which is the best, and telling them that nothing is going to be 100% going to give you success rate except the tracheostomy. And even tracheostomy, there is a paper that the patients with negative loop volume, negative issues with the lung issues, they may not be able to do well even with tracheostomy. So nothing is 100% in this world. So these are the various points to be discussed. So let me explain a case, a 53-year-old male with the snoring and sleep apnea. So he feels choking during sleep with throat irritation, diabetes, hypothyroid, and hypertension. All features of comorbidities are there, alcohol regular consumption with a BMI of around 31. ES is about 19 out of 24. With a mild DNS to left with turbinate hypertrophy, crowded oropharynx, edematous palatal alveolar, FTP4, you can't even see the soft palate kind of. Tonsil grade is 2, lateral pharyngeal band hypertrophy with normal facial maxillary profile. And AHI is around 104. Severe OSA. You can see the entire night he was desaturating like anything, but nothing less than 72. Because it's all short apneas, lifestyle modification, diet chart, counseling, sleep hygiene, everything explained, endocrinologist and cardiologist opinion obtained. The patient was put on CPAP titration. So first auto CPAP is being given. The pressure was set between 4 and 20. The 95th percentile pressure was 19.9 and the maximum goes up to 19.9 because more than that the machine can't deliver, and the patient was not able to tolerate. Then he was put on BiPAP where the pressure setting was between up to IPAP was 25, but still the 95th percentile was 24.4 and the maximum was going 24.8. The patient was not able to tolerate. So finally, what will happen? The patient will not use the machine and he will keep the machine aside. So you can see here how the pressure was hitting the roof. So the dynamic MRI of the patient, where you can see entire palate and tongue base is getting obstructed. So type 2 collapse. And this is what I shown you, the targeted sleep endoscopy, where you can see the palatal collapse and tongue base collapse. Just crossing the palate, you are not able to see the larynx at all. What you are seeing is straight forward tongue base. Nothing. That's a postpharyngeal wall. So this kind of severe OSAS patient, he is not a right or good patient for surgery, but still he is not able to tolerate CPAP. So we have clearly explained the patient that post-op CPAP may be needed, and patient has been prior sensitized about this, and we have planned zero palatal with tongue base excision with turbinoplasty. So let me share the clip. So after routine tonsillectomy, a W-shaped or butterfly wing kind of shaped excision of the palatal mucosa is being done on the soft palate on either side. This is right side and this left side. So both sides the palatal mucosa is being denuded. We should not cross this point. This point is actually midpoint between the base of uvula and the hot palate soft palate junction. And now we are removing soft tissue in the supratonsillar area pad of fat along with minor salivary glands. You can see the muscle fibers. They are the palatoglossus, and that's the tonsillar fossa. Hope the video is clear. Now I'm dividing the palatoglossus muscle to get a maximum lateral expansion. This video is not an edited one, but it is running a little at 2x, I think, 1.5x or 2x, little faster. This coablation technology is basically on a radio frequency technology. It creates plasma in the tip when it comes in contact with sodium ions present in saline. So that excited ion dissociates the tissue bond and makes a bloodless field, coagulates simultaneously and stops bleeding. This is actually a very vascular area. If you even just scratch happens, bleeds like anything, and but it stops. Now that palate is almost made half thin, and now the uvula is denuded and divided. The palate is now being divided in the midline the monopolar artery. This will be divided and pulled laterally. This division is very important. Too much of division will cause velopharyngeal insufficiency. Sometimes it can be permanent. So now we are redirecting the soft palate mucosa laterally by creating a scar vector laterally and anteriorly. So this creates an airway in three-dimensional way. As we have reduced the height of the soft palate, it increases the distance between the palate and tongue base. As we have pulled it forward, it creates more space in an anteroposterior dimension. And also we have pulled it laterally so that it creates the airway in right to left dimension. So it creates three-dimensional airway expansion. This is one of the versatile procedure, but it is an aggressive procedure and may end up in velopharyngeal insufficiency if not done properly. And it is being reserved for severe OSAS and also in revision cases where the primary palatal surgery fails. So for the same patient, we have used 70-degree endoscopy to visualize the tongue base, and same coblation is being used. You can see a huge tongue base being removed with coblation wand. We usually start in the midline and go laterally, but we should not go too much laterally. That's from the midline 1.25 centimeter this side and this side. Just 1.25 centimeter to maximum 1.5 centimeter. That central wedge portion is what we are removing it. We go down to the level of valvula. Too much of going laterally, maybe superficially we can do if you see a lot of lingual tonsil. Going deeper and deeper laterally, you may likely to injure the lingual vessels and nerves. So let me go a little forward here as you are able to see the epiglottis coming into the view. At the same time, we also remove the mucosa of the lingual aspect of the epiglottis so that we promote the scarring in that direction. Sometimes even if adhesion happens, we are happy. The adhesion between the epiglottis and tongue base by removing the mucosa on either side. Thereby, the epiglottis is being pulled towards the tongue than into the airway. So this being removed slowly, and then finally you will reach and you will be able to see the valvula comfortably. So here, these area are highly vascular. At the same time, if there is any bleeding, bleeding control is very important, and it has to be trained well to handle this area with endoscope, one hand and one hand wand, etc. And you should be able to do external criteria ligation in case if you have injured anomalous or abnormal course of lingual artery, which we may not know before surgery. Okay. So this is a postoperative video after 3 months. You can see how the scar is being formed in the palate. So you can see how it is being pulled laterally and anteriorly. And when you go behind, you can see the post end of the septum and terminates everything and how much airway space has been created in this patient. Let us come to the pediatric OSAS for some time. So the commonest reason for pediatric OSAS is enlarged adenoids and enlarged tonsils. And every snoring child has to be evaluated. That's a dictum. Every snoring child has to be evaluated. That evaluated means it is an pediatrician and ENT examination, not a sleep study. If there is enlarged adenoids and tonsils, grade 4, surgery is the best option. At the same time, if it is grade 2 or 3, trial of medications can be done, and if not improving, better to remove it surgically. Basically, same coblation instrument is being used. As I told you, it works in the principle of radio frequency, and it is bloodless. And you can see here, this wand is a different wand. it is being used to ablate the adenoid tissue. It basically it dissociates and actually melts like a butter and absorbs the tissue. You can see how it being done. And the orange color glow, what you see is the plasma, which is being formed at the tip of the wand. So by the older technique was a dissection technique or curettage, where it is being blindly done. Now what we are doing now is with coblation, where you can actually see what you are removing and how much you are removing. And we can create almost bloodless dissection and field. Okay, so same way, tonsillectomy is being done here. Just takes about 1 minute or less than that. You make the incision in the anterior pillar and a small bleeder here noted. And if you're in the right plane, you just go across the tonsil and done in a minute. You can see not even ml of blood loss is there. And these are all surgeries being recommended in patients with bleeding diathesis or patients who have cochlear implant where you can't use diathermy. These are all safely can be used. Drop of blood came and can be stopped immediately because this wand has three functions. One, it can dissect the tissue. It has a suction unit. It can stop bleeding. Along with that, there is an irrigation channel where the saline is coming. So that's why it is being called as magical wand. So the small group of patients has we come across is upper airway resistance syndrome. That is primary snoring, and next to that upper airway resistance syndrome where there is no deep severe desaturation, but these patients will have daytime sleepiness. These patients also can be treated with multiple, these are all can be an OPD procedure, simple minor procedures kind of, where we can do multiple RF or coblation application to the soft palate or cautery assisted palatal stiffening operation. Here you can see the probe is being inserted into the palate, wait for a minute. Basically, we are scarifying the soft palate to make the vibration less. And here, coblation assisted developoplasty is being done, where when you see come across huge edematous, long uvula, this all to be evaluated with dyes before performing these procedures. So when there is severe retropalatal collapse, there are various surgical options there. All depends upon the pattern of collapse. So for example, when there is an anteroposterior collapse like this, you can see in the dice, the palate is moving in this direction, anteroposterior. Then we have to pull the palate anteriorly. So these are the options available, like ubulopalatal flap, zetopalatal pharyngoplasty also can be done. And transpalatal advancement pharyngoplasty is a skeletal procedure. That is also option is available. Here it is an ubulopalatal flap is being created. This is a routine tonsillectomy. After that, palate is being dissected and a raw surface is being created for the palatal mucosa to be reflected. So you can see here, so this entire area is being made raw and the mucosa over the uvula is being denuded, and then a small area is being created here to accommodate the uvula, and then everything is sutured in two layers. This is like reflecting the uvula back anterior and to create more anteroposterior space. This kind of circular collapse, which we have seen earlier, in this dice video also you have seen earlier, this kind of circular collapse, zeta palatal is one of the best surgical option where you will be able to open up the airway in all three dimensions. So lateral wall collapse, you can see in this MRI where the lateral wall is being collapsing. And in the same patient's diagnosed sleep endoscopy, you can see the lateral wall is coming and blocking the passage. What you are seeing here is the uvula and soft palate, and these two are the lateral pharyngeal wall at the level of velum from the nasopharynx, almost like. So in these patients, Fairbank's technique or relocation pharyngoplasty, expansion sphincter pharyngoplasty, bar pharyngoplasty, various modifications of these procedures are being done now, which basically you have to pull the lateral wall further lateral so that the lateral wall will not collapse from the oropharynx. You have to tackle what is happening behind the palate. So this is expansion pharyngoplasty. These marks are being made. That's the base of the uvula. This is midpoint between the palate and the hard palate and the base of uvula. And first step is tonsillectomy. Now I'm making a parauvular cut to make the uvula shorter, and these all tissues will be removed to create a kind of neo uvula. I'm fast forwarding at this step as we all have seen the tonsillectomy. Now the palatopharyngeus muscle, that's a posterior pillar, is being elevated out of this space, and the lower end or the inferior pole is divided and will be pulled laterally. So both sides that has been performed. Now from the pterygomandibular raphe, the stitch is being taken and it goes towards that muscle and go around that muscle so that it won't cut off like a fair of 8, and then pull it back towards the pterygomandibular raphe and make a knot there. So there are various modifications. How you do it depends upon the individual patient and your technique. While you see the improvements, you will improvise your techniques. So when you pull this muscle, which has attachment till the upper velum, when you pull the muscle lateral towards the pterygomandibular raphe, that tightens or widens the lateral airway space. This different patient, different technique. So here the muscle is being elevated. Usually these patients, this lateral pharyngeal band will be very much hypertrophied. So tonsillectomy is being done. Muscle is being elevated without any mucosa on both sides. Entirely raw muscle. Parauvular cut and being done. And here you can see a small tunnel is being made to make pull the muscle more lateral and tightening it, and you can close it. So all depends how much thicker and how much scar you want. So more the dissection that side, more the scar will be formed. Tongue-based surgery, yes, we have seen this procedure. All depends upon the Morse classification A, B, C, D. A is upper tongue-based obstruction, and B is upper tongue-based and epiglottic obstruction, and C is the entire tongue-base along with epiglottis, and D is primary epiglottic obstruction. So the various ways to enlarge retrolingual space, a soft tissue procedure or a skeletal procedure. This is soft tissue procedure which we have seen. Skeletal procedure commonly done on mandibular osteotomy along with hiatal myotomy and suspension. This is how we create the window. This is a part of actually a facial-maxillary surgeon's purview. Usually we do it along with them. When we do soft tissue work, they will do this bony work. Basically, this genioglossus muscle gets attached to this genial tubercle here, and that will be pulled forward to improve posterior airway space much more. And also it increases the tension. This is a genial tubercle, and I have to understand the relation between the teeth and the genial tubercle. And this short clip will show you how this procedure is being performed. Sublabial incision is being made and the lower jaw. You can see there it's being elevated, and then a rectangular window is being created in the labial cortex, then will go through the medulla, and then you will reach the lingual cortex. So once this window is done, you will be pulling this forward and fix it with plates and screw. So that puts tension to the genioglossus muscle. There's another patient, same procedure, but here you can see it is much more wider. All depends upon the genial tubercle. So you can see the muscle fibers there, which is getting attached. This also being fixed to the mandible. So that much thickness will be the advancement will happen. Sometimes we may do the entire lower part of the mandible pull forward. That's what we call it as sliding genioplasty, where the genioglossus muscle along with digastric and mylohyoid, all these muscles will be pulled forward. You can see here the entire lower part of the mandible is being pulled forward. These are all nowadays being done along with mandibular advancement or maxillomandibular advancement. So mandibular advancement where we do a sagittal split mandibular advancement. We split the mandible parasagittal plane and pull the mandible forward. It is very difficult to record this procedure also at the same time to explain. Here, first step, they are removing the teeth and making all the cuts to pull the mandible forward. This instead of this video will make you easy to understand. You can see here the cuts are being done in the inner cortex and then in the midline and then in the outer cortex. Thereby, they are preserving. We have to preserve the inferior alveolar nerve. That's a mental nerve which comes out through this mental foramen. Otherwise, the patient will have a paresthesia. This is how the maxilla also being advanced. So sagittal split, mandibular advancement is being done. It's being pulled forward. And then this portion will be divided. And that's how the inferior alveolar nerve comes out. That will be preserved. So that enters into this segment and comes out of that segment. It's being fixed with plates and screw. So this much advancement will be happening. Along with that, when you further do a sliding genioplasty, it advances further. So this is sagittal split mandibular pulling forward. This is maxilla pulled forward. So that's how the maxillomandibular advancement is being done. So as I told you, tracheostomy is not the last one option. It can be done. It totally bypasses the airway obstruction, and it is indicated in severe OSAs with low oxygen saturation and cardiac arrhythmia patients who are not fit for major surgery. It's not only being done in adult patients, even in pediatric patients and neonates, especially who are finding it very difficult to breathe immediately after birth, can be performed in syndromic children where they are not able to breathe. So this is a kind of permanent tracheostomy where you have to create flap and make the epithelialization happens nicely in the tract. And so many stoma tubes are available which can be used permanently and keep it open at night. So to conclude, scientific evaluation of both anatomical and physiological correlation is essential. And sleep MRI with dyes helps to establish the site and pattern of obstruction. That is more important to choose the surgical procedure, which depends on the pre-op anatomical staging and the polysomnogram. Multi-level surgery increases the success rate, no doubt about it. At the same time, you have to keep in mind that multi-modality treatment is also needed in some patients. Surgical procedures are safe and effective in properly selected cases. Selection of surgical technique is more important than the technique itself. You must have seen that these surgical techniques are easy and can be mastered after seeing few cases or after doing few cases. However, although not always curative, sleep apnea surgeries will often achieve enough treatment effect to recur significantly less therapeutic PAP, making tolerance and compliance more favorable, which the case I explained to you. So the current research should aim to optimize and validate the other parameters to assess the surgical outcome rather than just AHA alone. Thank you.
Thank you, Vijay. That was a very good show showing procedures I think it would have been useful for many of the general practitioners who would have not come across these surgery procedures. Finally, the take-home message is very clear. So it's a multidisciplinary treatment. It's a multidisciplinary diagnosis, and any treatment which is being done for any sleep surgery, you don't give a 100% result, or you don't give an assurance of 100% like patient is getting cured of this. So if the aim of this treatment is going to be to improve the lifestyle at whatever cost it may be. So any questions from the audience, you can just put up, I can ask him. You can ask directly if you want.
Sir?
Can you hear?
Yeah. Sir, this is Dr. Sundaramurthy, pulmonologist, Chennai.
Yes, sir.
I'm student of Kameshwaran.
Yes, sir.
Regarding this surgery, any absolute contraindication? Because
Yes.
as a physician, I should know when not to refer or any absolute contraindication for OSA surgery.
Excellent. That's what I started. So the patients who are not really OSA, like central sleep apnea and other sleep disorders, sometimes may be wrongly diagnosed as OSA and may be treated, especially patients with central sleep apnea. So that's one part. So the second part is about patients who have severe comorbid conditions like cardiac arrhythmia, alcoholic, or who may not fit for surgery kind of people. So third thing is about the patient's expectation. So patient's expectation, he may be expecting that all his problems will be solved out of the surgery, and who are maybe very much depressed. So those kind of patients has to be treated with behavioral therapy, psychiatrist opinion, everything. And then once he is understood the real problem, then he may be a candidate for surgery. Otherwise, the first thing to know is when not to do the surgery, and you have rightly asked that question.
Yeah, only one clarification. After surgery, should he totally stop CPAP?
No. So that's what I always tell the patient, that you may need CPAP even after surgery. So all depends upon how your body responds, or how the scar is being formed after the surgery. So that will take minimum 3 months to 6 months time. So at least 3 months you have to wait. If the condition worsens, at the end of 3 months, we can do sleep study, or else it is recommended like that. Or else at the end of 6 months, we can reassess the patient by doing a PSG and drug-induced sleep endoscopy to see and evaluate how much remaining apneas are there. If it is significant desaturation along with that apnea or with sleep disturbance, the patient may need further treatment.
Yeah, this is the main concern of many patients.
Yes, whether it is pediatric or adult, follow-up and re-evaluation is very important.
Yes, sir. So the take-home message is clear. I think there are no questions. We can close the session, sir. Yes, I think there are no more questions. On behalf of IMA Tamil Nadu State Branch of CGP Wing, I would like to thank all the participants who have been staying in large numbers till 15 minutes past 7 to follow what is happening. And I would like to specifically congratulate and thank the speakers for the day, Dr. Nandagopal, Dr. Dhanashekhar, Dr. Anand, and Dr. Vijay Krishnan, who are all busy practitioners. In spite of their busy schedule, they have been logging in before because we are more than 2,800 registration, so that they cannot come in before everyone comes in. And I think it has been useful, and I thank you all from the bottom of the for the subject gratitude shown to the CG Wing of Tamil Nadu, sir. Thank you, Vijay. Thank you, sir. Thank you, Rashika, sir. And thank you, Anand, sir, for giving me a wonderful opportunity. Thank you, sir. Thank you very much, all. Thank you, sir. Bye.
be having a trial.